My apologies for that. Can we give the Minister a few minutes just to join up, please? I believe she's trying to get hooked up online. Thank you. We'll open in a moment. Health in the Western Cape Provincial Parliament. We welcome the members of the committee. We welcome the Minister in a temporary absence. We welcome Dr. Klute, who's joined us online. Thank you, Doctor. Officials of the Department of Health and Wellness, members of the public, both present and those who are joining us virtually, you are most welcome to this meeting. Before we proceed, let's take a minute to reflect. Thank you very much. Members, before we go on, I would like to remind all those in attendance, and specifically online, of the Western Cape Provincial Parliament rules for online conferencing for the virtual platform, and I'll read it out. A, all participants are advised to mute their microphones. B, that chat functions are used for points of order only. C, that participants must raise their hands and identify themselves when speaking. D, advise everyone to turn off their mic and the video when not speaking. E, advise everyone switch on their mics when they are speaking. And F, advise everyone to switch off their mic and video when done speaking. With that, has the Minister joined us?
Yes.
I believe the Minister has joined us. Welcome, Minister. Your hand is up.
Good afternoon, Chair. Can you hear me?
We can hear you, Minister.
Oh, okay. Sorry, thank you. I'm on the road, so I will be switching off the camera once I start speaking when I do the introductions. I'm just sorry, because if you could remember, Chair, the initial date was Monday, but we have to accommodate this afternoon for such, but I'm on the road coming from the West Coast. I'm here. Thanks.
Thank you, Minister. You're most welcome, and drive safely. Are there any apologies?
No apologies, Chair.
No apologies. We will then proceed to the introductions. All of the committee members, first those in the chamber and then those online, and after that the officials and then members of the public. So please, if the members in the chamber can please respond.
Thank you, Chair. Good afternoon, and good afternoon to the officials. Good afternoon to the members of the public. My name is Christopher Fry. I'm a member of this standing committee.
Good afternoon, Chair, all the members. Dan Plato.
And I'm Gerrit Pretorius. I'm a member of this committee, and I'm chairing this committee. The members online.
Good afternoon, Chair and members. My name is Rachel Vogel.
Any other members online?
Good afternoon, Chair and the members inside. My name is Ayanda Barnes, member of this committee. Also, Chair, I want to render an apology for Member Baku Force that is unable to come in today. Thank you.
Thank you. So noted. Thank you, Member Barnes. Any other members online? Fine. We will proceed then to the officials in the chamber, and after that to the officials online.
Thank you. Good afternoon, Chair. Good afternoon, members. The name is Simon Kay. I am the DDG for Corporate Services in the department.
Thank you. Afternoon, Chair. Afternoon, members. I'm Sadiq Karim, Chief of Operations.
Good afternoon, Chair and members. I'm Nonhlanhla Andangosi, Chief Director Strategy. Thank you.
Good afternoon, Chair and members. I'm Glenn Carrick. I'm the Chief Director for Financial Management.
And we move then online.
Good afternoon, Chair and committee members. Keith Klute, I'm the head of department, and my apologies for not being in person. I'm currently ill, in isolation. There are other members online that I will ask them to introduce themselves, starting with Ms. Ching.
Good afternoon, colleagues. My name is Karen Ching, and I'm the Director of Strategy, Policy and Planning in the Department of Health.
Thank you, Ms. Ching. Dr. Angeleti Tutwe.
Good afternoon, Chair and members and colleague. Laura Angioletti Dutue, Chief Director, Facility Infrastructure Management.
Thank you, Dr. Tutwe. And then Dr. Moodley.
Good afternoon, Chair, members, colleagues, and members of the public. I am Dr. Melvin Moodley from the Health Intelligence Division of the Department of Health and Wellness.
Thank you, Chair. That's all the departmental officials.
Thank you, Dr. Klute, and all the officials who introduced themselves. We'll now go to the members of the public. We will start on my left. If we could start with the lady over there, please, to introduce herself.
Good afternoon, committee. Damaris Kiewitz.
Sorry, if you could say who you're representing as well. My apologies for not saying that.
Cape Metro, Health Forum.
Good afternoon, Chair. The name is Graham Lindos, Tygerberg Sub-District Health Forum.
Good afternoon, Chair. I'm Amanda Davids, Tygerberg Sub-District.
Good afternoon, Chair. Barbara Nieuwoud, Sub-District.
Good afternoon, Chair, members, department, and the rest of the public. Christina Nomdu, Western Cape Commissioner for Children.
Good afternoon, Chair, members of the public, and members of the House. I'm sorry, Daniel, Government Monitor Mentor.
Good afternoon, Chair and members. I'm Tessa Goldschmidt from the Office of the Western Cape Commissioner for Children.
Good afternoon, members. I'm Vimbawa Tambo. I'm a child government monitor under the Children's Commissioner.
Good afternoon, Chair and members. I'm Tori Hendricks from the WCCC. Thank you.
Good afternoon, Chair, members of the Parliament. My name is Johnny Plakis, Child Government Monitor for the Children's Commissioners.
Good afternoon, Chair and members. I'm Leslie Sylvester from the Klipfontein Substructure District. Thank you.
Good afternoon, Chair. I'm Megan, and I'm part of the Commissioners Group.
Thank you. Did I miss anyone? Can we proceed then? Thank you. With that, with all the formalities behind us, we're going to move on to the Minister to give her the opportunity to give us a brief overview and remarks on the budget. Minister, over to you. I hope you're still with us.
Yeah. I'm here, but I'll switch off my camera. Thanks. Thank you, Chair, the members, Provincial, Western Cape, and also the representatives from the communities and everyone who's there. Thank you again for having this opportunity for us to present Vote 6, Department of Health and Wellness for the budget year 2023-2024. Chair, often for the past, I think it's going to be 9 years that I've been presenting the budget for this department. During this period on the budget here, in most times, despite that you'll have an increase in the population, the quadruple burden of disease, but in most times you'll find that there's some elements of the excitement when at least you realize that there's been an increase in the budget, in as much as that it might not necessarily that it could cover everything. But for the first time that we are presenting a budget post-international pandemic that has crippled all the health systems anywhere in the world, but specifically in the context of the Western Cape and South Africa, a pandemic that also post-pandemic, although it's still there, but find that it comes at a time when we have seen some of the other social ills that are beyond the health system. When we have seen how crime and violence has impacted on us, the health system. We're presenting a budget at the time that we have got what we call load shedding, the blackouts. where health facilities are not exempted except those few. I'm talking about as a policy for the country, except for those few, meaning that there's also no additional money for such. It means that we have to take money from us ourselves. We're presenting a budget at the time that we will be losing almost 400 plus of our healthcare workers who are appointed through the contract at the time for the COVID. This is the budget that we present at the time that we're still not sure exactly what's going to happen with the wage bill in terms of the salary increase, which we as the provincial health has to absorb in as much as that we don't even participate in the space of the National Bargaining Council. Chair, this budget is also presented at a time where there are uncertainties for also other categories of our healthcare workers, for example, community health workers, where it has been dragging throughout as part of the national health system. But lastly, Chair, it's the first time that we have a budget where the equitable share has gone down, where the conditional grants have gone down, where actually we are regressing. Because in as much as that you might do the comparison, you say pre-pandemic, we would have about 24 billion, and then 2020, 2021, 27 billion, and then the last one, it was about 29 billion. Now we are appropriating about 804.5 billion of the budget. And in as much as that the provincial treasury has tried as much as they could to try to rob Paul and pay Paul in, which they did actually during the pandemic, because there was no extra money per se, except for the COVID monies that were put part of the grant at the time. Because now it meant that other departments also they have to do what they have to do. And also as a province, we need to also fix and see how we can be able to provide, for example, the energy crisis in terms of renewable energies. It means that they could only help us up to a certain level. So this is the budget that we are presenting. It's quite gloomy and there's nothing exciting about it. I'm feeling depressed even now that I'm here in the Viscus, where people find that they are trying as much as they could under the circumstances. Last week, I was following the money where we had additional money for the mental health, 30 million and 20 million for the surgical backlogs. But now we'll find that all of these have to be incorporated within, but there's no any other additional monies. But at the same time, we cannot just be unhappy throughout, despondent just because the weather is bad. There are other excitements in regard to, for example, the violence prevention unit, which have taken over and the progress actually that has been happening. We are excited that in as much as that the weather is bad out there, at least we find that we've got dedicated staff members who makes Western Cape Department of Health and Wellness as their first choice of work, despite the kind of a situation. So the issue of the staff wellness programs still continue. The issue, that's because we don't have COVID, the pandemic is brought out there. The issue of still going ahead with the vaccinations, despite that we are losing many of those staff members, healthcare workers who were appointed as part of the COVID money to render the vaccinations. We're excited that we, in that space of mental health, we still have got some of the projects in the pipeline for where we strengthened, for example, as part of the pilot in the in the Witzenberg, in the Klepfontein, and also other parts of our province in regard to that space. We're excited to still using these robotic surgeries, although they are still expensive machines, but at least to reduce the length of stay among for surgical backlogs, and also continue adding extra days of theaters in some of those. And then lastly, Chair, we need to understand that in as much as that we are looking in terms of the increase in the population, in the monies that we are not getting from them, for example, from the RAF and all of those, but we still have to go ahead and strengthen our health system. So it is exciting actually to see that we are working closely with our private counterparts, and also where we also share spaces through Indaba and everything with our community reps through clinic committees and so forth. And then also that actually with our Indabas, we are going ahead to see how we can also explore some of the pilots in related to the universal health coverage, the way to go in regard to making sure that we provide an equitable and affordable health services towards strengthening the whole of the country health system that is in future. So, Chair, Dr. Kluti and his team, they will analyze exactly where are the shortfalls and also what are the other interventions that we should try to make sure that these are the non-negotiables, in as much as that we have to let go and some of the other things that we're supposed to do, because at the end, we are the only sector, we are the only department that works 24 hours, 7 days a week, 365 days a week, that has got no policy that says, we are full. It's the only department where even if people are sardines, are squashed and everywhere, and if there is a 25 people, whether they've been injured or what, there's an outbreak, you still have to accommodate them without saying that, can I get an extra budget? That's the only department. It's the only department that tries to fix some of the inequalities and other challenges that are happening elsewhere that would have been perpetuated or that have been left behind by the other systems. Just like here, where am I now in the Verskos, Matsukama, where there is no public transport. People have to pay 1,200 rand all the way from the Kleperand in order to come to the Vredendal Hospital when it so happened that there's no transport. Because you'll find now they rely on the ambulance, which is supposed to be emergency, but for them, because there's no other means, they also use it for medical instead of emergency medical services. And it's not the health's fault that we've got that kind of a situation that is happening out there. And then lastly, with the inflation that has impacted mostly because of the wars in the Ukraine, the issue in terms of the China, where we find that we rely on them, especially the pharmaceuticals, where everything now is increasing, is going up. And also about the climate change aspect, which we know that health as a sector throughout internationally is a major contributor, but it's us who have to fix it through, I think Dr. Angela Dutoy can show in terms of what also we are busy doing, we have done in regard to not only with the changing the lights and the bulbs, and also how we are creating the green global hospitals in regard to being ready throughout. Thank you very much. Over to you, Dr. Kluter.
Thank you, Minister. Dr. Kluter, if you wish to add, you're welcome. Dr. Kluter, we can't hear you.
Sorry, Chairperson. Thank you very much. Just to add to the Minister, the following observations. I would say that as a healthcare system and as a Western Cape Department of Health, from April 2020 till March 2022, we probably faced the biggest, let's call it, biggest single challenge that we have faced as a healthcare system. And it called on our resilience to respond, to deal with, up to that point, 4 waves of COVID in the space of 2 years. As we enter April 2023, we're about to deal with what one of my colleagues in the room, Mr. K, would say, it is the next big test to our resilience. We're entering a 3-year period where the financial situation is of such a nature in the country and such a nature in this province that our healthcare system, and that is what Minister Mbombo is referring to, the one system, the one universal social care network for all the people in the Western Cape is about to face probably the next big challenge for the next 3 years. And that challenge is that we have a financial situation that increasingly we will have to make very, very difficult choices. And the choices we will make will invariably impact on the poorest of the poor that we serve in this province. So as we've come out of the 2 years of COVID, we are going into this 3 years of financial austerity, accepting that this is the situation that we're going in, chairperson and committee members and members of the community, but also accepting that we go into this with full responsibility of the weight of the responsibility that we have to make informed choices, walk a path with everybody in this province, and really walk this journey to say health and wellness is everybody's business. Therefore, we walk with yourself, chairperson, with the committee. We walk with our community members in that forum there. We walk with the Children's Commissioner and the child advocates. We want to walk a journey of walking this together. We have a commitment that we walk it with multiple partners and multiple stakeholders to do this jointly. We already started doing that with our universities, because as you will share with you, the biggest bulk of where the shortfall is visited on and the biggest impact is felt in this first coming year is on highly specialized services. So it is where our universities are working jointly with us. It is at Grootskeer, Tygerberg and Red Cross. Those are the areas where we're already working with our academic partners, with the universities to walk this journey together. The biggest area where we have saved to the best of our ability, and we have the statistics and the data to back this up. The poorest people find their biggest use of a healthcare system is in primary care facilities, in community-based services, and first-level hospitals, which is district hospitals. To the best of our ability, that is where we try to buffer our response. We've tried to buffer our response also in emergency medical services. We try to buffer our response in the areas where the most vulnerable of our communities are left most vulnerable and in care of our system. So when we take these choices and we're about to present these choices to you, it's taken from that perspective, that we know that we must mitigate the impact on the most vulnerable. There was always a colleague of ours that reminded us that we are the social safety net for the most vulnerable. We are going to feel it in the next 3 years. The most vulnerable is going to feel it with us. We're asking everybody to walk a journey with us. Thank you, Chairperson.
Thank you, Minister, and thank you, Doctor, for the background and the context. That's much appreciated. Members, we will then proceed with the tabling of the budget, page by page. You know the story or the procedure. So the first pages that we will cover and ask questions, if there are any, are from pages 221 to page 234. It was a bit difficult to divide this up, but this and what is to come was the best that I could come up with, practically. So it's page 221 to page 234. Can I have an indication whether there are any members who wish to pose questions at this point? Online? Member Windvogel? Member Barnes? Member Windvogel's hand was first up and then Member Barnes. Member Windvogel, do you wish to ask a question?
Yes, Chair. Am I audible, Chair? Can you hear me, Chair?
We hear you clearly. Please proceed.
Thank you so much, Chair. My apologies for my voice. It was
a victorious day for us yesterday. So that's the reason for my voice as the leading party of the country. Nevertheless, Chair, the Minister, I welcome the input by the Minister and the HOD. In the foreword of the Minister, she mentioned about the 400 plus workers that will lose their jobs. Now, Chair, I want to touch on those workers, especially at Brackengate Hospital. I assume they are also part of that.
Member Van Proegel, there's a lot of background noise. If we could perhaps try and phase that out.
Okay.
Thank you.
Is it better, Chair?
Not really. Is there a door that you could close, perhaps?
Perhaps let me move to a different location while you are giving Member Barnes a chance to ask the questions.
Thank you,
If you permit me.
You are welcome. Thank you, Member Van Proegel. Member Barnes.
Thank you, Chair. I hope I'm better audible, Chair.
You are absolutely clear. No interruptions.
Okay.
No white noise.
Thank you, Chair. Chair, let me start by welcoming the inputs from the MEC and from the HOD. I must say, as much as the MEC said that the budget was not appetizing, there was a highlight she mentioned when she said of other departments that are not assisting in terms of transport. When you look at the Department of Health, one of the biggest challenges one will note is always patients getting them from one point to another point. I think it's something that I've always raised, especially in the rural areas where there's no means of transport. You ask yourself in this government, how is this taken serious? One patient moving from Cape Town 2 days to from the Karoo to get 2 days to hospital in Cape Town, Grooteskiel, for example. So for me, it was very appetizing to hear the minister speaking today of that specific challenge, that in a way other departments should also come to the party to assist the Department of Health on that one, which is a burning issue. Chair, my question is on page 223. Under compensation of compensation of employee COE. The COE budget, just 1 second, Chair. The COE budget in 2023-24 reduces by 1.91%, but increased by 1% in each of the outer years of the 2020-23 MTFE. Chair, what I would want to know is that why is the COE budget reduced? What will be the impact and the number of jobs that are affected? Secondly, Chair, how much is the province's expenditure for municipal services? My second question then, Chair, will be on page 225, outlook for the coming financial year 2023-24. Emerging priorities for the coming year include the continuous monitoring of the COVID-19 pandemic. What I want to know, Chair, is that how does this budget respond to the burden of mental illness? What happened to the budget to procure Western Cape vaccines? Why is it not used to address mental illness in the province? And then my third question, Chair, will be on page 226, under the first bullet, agency personnel. How much is spent on agency personnel, and what are the plans to reduce spending in the department's over-reliance on agencies personnel? And then, Chair, my other question is on page 238. Under table 9.2, summary of payments and
Member Barnes, we're not on page 238 yet. If you can just hold that.
I thought you said we are up to 240, Chair.
No, 234.
2, 3, 4. Okay. Apologies then for that one, Chair. I will park then up until we get another chance. Thank you, Chair.
Thank you, Member Barnes. Member Windvogel, are you online again or with us again?
Yes, Chair. Am I audible?
Yes, very audible, very quiet. Thank you. Very clear. Please proceed.
Thank you, Chair. Chair, so my question on the issue of workers losing their jobs. I just want to check the HOD. The HOD, Dr. Keith, referred to them as frontline heroes. And a decision was taken to use the hospital, the Brackengate Hospital, as a transitional care facility since the 1st of July 2022. So now I want to check with the Minister that still in 2022, the lease was extended for 5 years. And I've seen the HOD's reply to the memorandum of the workers, in which she says the employment was based on contractual he says the employment was based on contractual agreement for the duration of the pandemic and the National Disasters Act. And that staff was informed since July 2022 that contracts will not be renewed in April. Now, Chair, how much was budgeted for Brackengate Hospital in this budget, and how much will be spent on vacancies? What is the number of staff that will be employed, given that contracts are terminated on the end of March, and that new staff will have to start on the 1st of April, and recruitment for new staff commence? What is the plan? Why is the department not employing the healthcare workers who risk their lives at Brackengate? So now, Chair, the cold phase of COVID, during the cold phase of COVID, so what options are there to keep these workers in their jobs, even if it's through extension of contracts and decision to fire these workers off and their contracts may be interpreted as heartless and backstabbing? And as the ANC, we really want an urgent committee meeting to discuss the Brackengate matter. And also with regards to the option, what does the department's People's Management Delegation in terms of the Public Service Act of 1994 or delegations in terms of the Public Service Act of 1994 and Public Service Regulation of 2016 say about absorbing these workers without advertising the post, and does it all for this? Then secondly, Chair, with regards to the JFU point of reference, there are 23 districts, 5 regional, 2 central, and 1 tertiary, and 1 specialized hospital, and 16 forensic pathology facilities in the province. With regards to the 5 regional hospitals and the identified need for Klipfontein regional hospitals, how much of this budget go into the building of Klipfontein Regional Hospital? Secondly, Chair, given that the hospital will only start operating in 2032, why are we not converting the KDH and MPH to a regional hospital? They already have some functions of regional hospital, so it makes more sense to convert one immediately. Why is the department opposed to this idea, and what will it be, and what will be the pros and cons of such decision? Then lastly, Chair, on page 222, first paragraph, second sentence, point of reference of particular concern is the increasing demand for psychiatric inpatient care and emergency care due to violence and injuries. Now, what are the root causes of these, and how are whole of government society approach used to address these issues?
Thank you, Member Windvogel. Before we ask responses to those, I also have a question. On page 225, under the heading number 5, reprioritization. It's a tongue twister. where reference is made to the phasing in of the use of the equity resource allocation and to mitigate the impact of the cuts on the delivery of health services to the people of the Western Cape, as well as reduce disparities in budget allocation between hospitals, districts and regions. We can just get more clarification on that as well. Thank you very much. Are there any more member questions for this round?
Chairperson?
Is it Councillor, sorry, is it Member Windvogel? I also see Member Barnes' hand up. Member
Yes, Chair.
Windvogel?
Yes, Chair. I don't know what happened because there was a last question from my side on the pages from 221 to 234.
Please proceed.
Thank you, Chair. The last one is also on page 221, the first paragraph, the fourth sentence. I just want to check, Chair, through you, what are the plans to improve vaccination numbers and whether the move by DA Deputy Speaker to invite Dr. Isim Malhotra is a sign that the governing party in the province support anti-vaxxers. What is the MEC and the department's response to the use of provincial legislature to host talks of anti-vaxxers? I just need clarity of a response from the department and the HOD on this. Thanks, Chair.
Thank you, Member Windvogel. Member Barnes, your hand was up. Is it up again or still?
It was a legacy hand. Apologies for that one, Chair.
No, you're welcome, Member. I see the hand of Laurie Lake. Is Ms. Lake a member of the public?
Yes, I am.
Ms. Lake, the members of the public will get the opportunity to put questions to the members once we have exhausted the budget, and then members of the public will get the opportunity to do the same. If you can bear with me, please.
Thank you very much.
Thank you. With that, Minister, if you wish to respond, or Dr. Kluter, but first the Minister, if she's available. Is the Minister with us?
It says on hold.
Doctor, if you wish to proceed in the meantime, thank you.
I will proceed. Thank you very much, Chairperson. Thank you to Member Windvogel, Member Barnes, and yourself for the questions. Let me start with Member Barnes's questions. So when it comes to the transport and the observations he makes, so Member Barnes, we are working with the Department of Transport and Public Works, and we are exploring, and that will carry into the Department of Mobility, transport options, especially for far out areas. So we've moved closer and we're trying to find solutions. So as solutions become available, we will start bringing in alternate solutions. We're leveraging of what we did during COVID, which was both using the the red dot system initially for Q&I, and then moving towards the red dot light system. But we're looking at options with that department. In terms of the COE reduction, the question that Member Barnes has asked, although it says 1.9% decrease in year one, our intention, Member Barnes, is to keep our staffing numbers even for the year. I'll ask Mr. K just to come back to just clarify the technical merits of that against a 1.9% reduction in COE. Then the question that you asked, the third one, was about mental health. Just to indicate that there is actually an increased allocation for mental health. We're going from 30 million of last year to a million of 70 million. And later in the submissions, we'll point out that we've increased our allocation to mental health. Then agency, the question that you asked, just to clarify again, and we clarify it every year, but I'm going to ask Mr. K just to clarify again, what is in the item that we record under SCOA and what we report on, and exactly what the agency allocations expenditure is, and what our process is in terms of dealing with agencies and moving to more full-time staff. Then for Member Windvogel, Chairperson, just to clarify, and I'm going to ask Mr. K just to clarify specifically that in the department since COVID started, we have employed 2,342 additional contract staff since COVID started. And Mr. K will explain to you that out of that 2,342 people, they were always appointed on contract. So that means you have a start point of your contract and you have an end date for your contract. Of the 2,342, we are sitting with a situation that 471 persons' contract expire and they have not been accommodated in anything else. So if you think from 2,300 to 400, and Mr. K must just explain those numbers. Of the 471 whose contract comes to an end, included in that is the staff members that are on contract in Brackengate currently. There is, and that is the big deduction of money that is in our budget this year. So from the 1st of April, and we'll go to the number, the allocation we got, additional allocation we got in the National Conditional Grant that pays people for COVID and pays them for vaccination, that ceases on the 31st of March. Therefore, anybody that has a contract against that budget line, the money disappears, therefore the contract cannot be honored. Therefore, of the 471 left, we still have all these other opportunities where people must apply like anybody else. When your contract comes up, you apply for a job, and if you're successful in recruitment selection, you are successful in the job. But there is a specific transition period, because in Brackengate, we have advertised post, we are going through a recruitment and selection process, and there is a transition period that we're managing with the staff in Brackengate, which is an internal management between us and the staff at the facility. But Mr. K will give the details in relation to that. To say that we are dismissing people or turning them away is incorrect. This is a contract that comes to an end. And like any other employee, people have the right to apply. And if they're successful, they go into another position, because to go from a contract position into a permanent position, you need to go through a recruitment selection process. Then the second question about Geef Jooste, what Windvogel is asking is, we already have what I would call hub activities. Like when we opened Khayelitsha Hospital, we had hub clinical activities. When we opened Mitchells Plain Hospital, we have hub clinical activities. For the future Geef Jooste Hospital or the Klipfontein Regional Hospital, we already have hub activities. And we already have people working, for instance, in the 24-hour emergency center in Heideveld. That becomes the staff for the emergency center in the future Geef Jooste Hospital. And there's a few other places where we have staff that's already in the system that immediately will then go into the first batch that goes into Klipfontein. Obviously, when we come to the completion of the hospital, we will advertise additional posts and we will recruit people in commensurate with the phases of us starting the service in relation to that. So as he rightfully points, there is a trajectory of us moving, and we are moving to work with our implementing agent to speed up the delivery so that we can commission and bring staff in. But like we've done with Geef Jooste, like we've done with Khayelitsha, like we've done with Mitchells Plain, there's a clear process in terms of how we will be commissioning the services when it comes online. Then question 3 from Member Windvogel around the mental health and violence. The root causes are very clear, Member Windvogel, because the root causes we contract to specific geographic areas. And we cannot get away from the fact that the root causes that underpins violence and the mental health problems is intertwined with socioeconomic conditions. And the socioeconomic conditions of COVID that has made it worse, therefore mental health and violence has increased in areas of higher socioeconomic deprivation. There are proximal factors that exacerbates violence and mental health in those places. The first one is substance abuse, alcohol being a key driver, and especially for violence, and then other substances, specifically TIC and other substances, a key driver for mental health conditions. But we also know, and it's been quite widely advertised, the free access to firearms is a key precipitating factor for violence. And hence, with us starting a violence prevention unit, we've just got the approval from the DPSA. One of the key things that the Department of Health will be concentrating on is to look at all these societal factors that are driving violence, and then to implement programs in the geographic areas where it's needed most to start driving and turning these social drivers around towards making societies whole in order to have less and less vulnerability for violence and for mental health in those conditions. So we really welcome Member Windvogel's interest, and we would really like to work with the committee on deepening that with our communities over the coming years. Then the vaccination drive, a very clear position from our side, Chairperson, and that position was released within 2 or 3 hours of the reported event of Dr. Malhotra speaking in the lunchtime at the Provincial Parliament. Our department specifically made a clear statement. We were not aware, we were not involved. With that, we distance ourselves from any anti-vaccination opinions that Dr. Malhotra holds. We're a firm believer that the scientific evidence for vaccinations is clear, and our commitment remains to be continuing the vaccination and extending it to protect the most vulnerable. So we have a very clear, unambiguous position in relation to that. And then, Chairperson, your last question. It's a very interesting question because, and again, Mr. K might just want to add, and he's come back just on a fourth clarification. But just to give you the board principle, Chairperson, the equitable resource allocation takes into consideration where, let's put it this way, where the population that is at greatest need live, how much resources are we spending in that geographic area in relation to need? And then we do it for primary care. And then for hospitals, we have a slightly different formula. But again, where the greatest need is, do we spend our resources accordingly? What we've done in this exercise is we have readjusted so that our allocations is now fair in primary care and fair in hospitals in relation to need. So what would have happened in this exercise, some hospitals would have lost some money, some other hospitals where there's greater need would have gained some money. Some primary care sub-districts would have lost some money, but some other primary care sub-districts would have gained more money. And it was a redistribution of money that's fairer in relation to need. And that is the principle of what we've introduced with us. So, Chairperson, if you just allow Mr. K just to give a little bit more detail, maybe not too much, Mr. K, but on the 4 items that I've identified. Thank you, Chairperson.
Thank you, Mr. K.
Thank you, Chair, and thank you, HOD. So let me answer the question around the compensation and explain it in a little bit more detail. So what Dr. Kuti has said is correct. We started with 2,342. Of those 2,342, 819 people have left on their own volition. So they've chosen not to continue. That leaves us 1,513. Of those 1,513, 819 have either gone through a recruitment and selection process and either find themselves in a permanent post or another form of contract post within the organization. That leaves us with 694 people. Member Windvogel, that includes 166 people from Brackengate, and it includes 57 people from Sonstraal. What we have as a department agreed to do, or we agree as part of our strategy, is to fund intermediate care. So we're now needing to move something that was of temporary nature into something that becomes permanent. You can't just, from a DPSA perspective, you can't just say, congratulations, you got a contract, we're now making you a permanent employee. You can't do that. So we're going through a recruitment and selection process at both places with undertaking that those posts will be permanent employment. Now, there's a little bit of consternation at Brackengate. And so what we have agreed with the proposal yesterday was that we will, for the Brackengate, we will extend those contracts for another period of 2 months while we complete the recruitment and selection process. And those people that are in those posts, those contracts, are welcome and encouraged to apply for those particular jobs. So from an equitable share point of view, basically the remainder of what the COVID posts are, including the intermediate care, we will incorporate those into our baseline as permanent employees. That leaves us with 471 contract workers who are on the short-term contract for the vaccination program. The vaccination program was funded at the national level until the 30th of April, 31st of March 2023. That 197 million rand is no longer in our baseline, nor is is approximately 428 million rand that we used of our service pressure money last year or this year to fund COVID and COVID-related activities. That money is also no longer in our baseline. So the sad reality is we have a tridemic of financial pain because the conditional grants have been cut at a national level within the health sector. The province has also been impacted by the revision of the provincial equitable share. And because the country is borrowing so much money, the reality is the service delivery programs are now starting to take a back seat. And there are some very, very harsh realities that we are finding. And you're seeing that come through in compensation, and in our goods and services, it's even going to be more dramatic because inflation is running at 7%, and we got, when you take the COVID money out, we got a 1% increase in our budget. And that is the reality. We will provide the questions on the municipal services. It's around 600 million rand, and we'll provide the exact amount around agency. But when it comes to agency depends on the need at a specific facility at a specific point in time. We are acutely aware of where the pressures are and at the specific facilities, and the facilities and the district managers are then empowered to make the correct changes that are needed to be able to continue the service. But the reality is we will still need to use agency staff in order to fulfill the need. There are areas that are of concern, and we've done a fair number of investigations with the teams about how best to manage that particular pressure. On the ERA, very briefly, so while we talk about phasing, there are ideals around the equity resource allocation model. But the reality is when you're not getting a real increase in budget, to start cutting even further is going to destabilize the system. So what we did is we had an amount of money which we had been, we didn't have certainty of it in terms of carry-through costs until this budget. And so we have, you'll see in our admin sector and our program 1, we have removed some money from there and we have pushed that into the service delivery programs. and we have disproportionately allocated it without cutting anybody's budget further in terms of the principles and the criteria that appear within that particular model. We're on a journey. It moves from historical budgeting. We are now on an equity resource-based budgeting. We want to move to outcomes-based budgeting. We're not there yet, but that is a journey that we're on. Thank you.
Sorry for interrupting. There was also a question on the agency personnel.
Yes, Chair. Sorry, I said we will give the numbers.
Oh.
So we will provide the exact numbers for the agency budget. But that was us. I was saying that the agencies, we are acutely aware of the pressures in certain areas in the organisation. We've done a number of interventions with those facility managers to start managing and mitigating those particular challenges. I think probably Khayelitsha District Hospital is the one there. There is a fairly substantial amount of agency expenditure that is incurred relative to the compensation, and we've got specific interventions that are happening in that space. The reality is we aren't always able to appoint the clinical staff that we would like to appoint. And so the reality is, in order to continue with the service, the facilities need to use agency staff to cover that service gap and that service need. But we are acutely aware of the agencies. Thank you.
Thank you, Mr. Kay. Dr. Kluter, if I might take the liberty as chair just to ask a very silly question. Is the phenomenon of making provision for violence prevention, is that an international or universal phenomenon at healthcare facilities?
What I would say, there are international best practices where if you really want to deal with the intractable nature of violence in a society, the international best practice is based on what happened in Cardiff, and that's where the Cardiff model comes from. But since then, it's been adopted across the world as a best practice. And the best practice is that you turn to a public health approach to violence. And what I mean by that is, you know that violence and crime is, you treat it like it's caused by social conditions. And the best international best practice for getting the right answers is to view it from a public health lens. And therefore you say, okay, how do we understand the root causes? Where does it come from? What is the interventions? What's the best evidence? What do you try? How do you do it? So the international best practice is to have an approach of a public health approach to violence prevention. And therefore, the starting a violence prevention unit in the Department of Health and Wellness in the Western Cape is a very progressive, internationally benchmarked practice. Does it answer your question, sir?
Absolutely. I wasn't aware of something like that would be required, but thank you for that. It's amazing. Minister, if you're still with us, is there anything you wish to add, if you did hear the questions? The Minister seemingly is not hearing us, although she seems to be online. Mr. Kay?
Chairperson, I have got the exact numbers. I said I'd come back to you, so if I could give you the numbers on the agency.
You're welcome.
Thank you, Chair. So the agency and outsourced budget is 94 million odd and 26,000. The municipal services for electricity is 353 million, and the other municipal services are around about 117.8 million. Thank you, Chair.
Thank you, Mr. Kay. Members, we will then, if there are no more questions on these pages, we will proceed.
Chairperson, my hand is up.
I didn't see that, Member Windvogel, but please proceed.
Thank you, Chair. Chair, it's just two follow-ups, on one on the GF viewers, and the second one on the Bracken Gate. Chair, can I continue, Chair?
Please proceed.
Yes, Chairperson, on my follow-up on the GF viewers, The HOD may have missed my question on why the KDH or Mitchell's Plain Hospital is not converted to a regional hospital while we wait for GF Joseph to be completed in 2023. Then on the Brackengate one, Chair, I get the explanation from the HOD, but what I want to understand is why not absorb these workers using provisions in the department's people's management delegations, which allow filing of posts without advertising. The reality is that there is a budget for transitional care for care facilities and workers are already in the system. So why advertise when you can just absorb these workers? Thank you, Chairperson.
Thank you, Member Van Vogel. Dr. Klute?
Yeah, thank you very much, Chairperson. So the specific reason why you see the designation of moving Khayelitsha and Mitchells Plain from a district to a regional hospital, while we are waiting for the commissioning of Klipfontein Regional, is I explained it to the standing committee last year, Chairperson. I'm now going to have to ask for forbearance because this is the explanation we gave last year. In the dispensation where we are moving towards, which is acute hospital care, the designation of whether you're a district hospital or whether you're a regional hospital becomes irrelevant. It is whether you have specialist services or not have specialist services. So in Khayelitsha as we speak, and in Mitchells Plain as we speak, the big general specialist services exist in those hospitals. So strictly speaking, Khayelitsha Hospital and Mitchells Plain Hospital does not sit with the definition of a district hospital because they are already specialist hospitals. The only difference between what happens in the specialist hospital that they have there and the ones that would be at, say, George Hospital or Somerset Hospital is for ICU bed capacity. And that ICU bed capacity is a very intensive capacity. But from a general patient and public perspective, all the general specialty services that anybody from Khayelitsha or Mitchells Plain would get in any regional hospital, they're currently getting in Mitchells Plain and in Khayelitsha. So there is no benefit in changing the name from district to regional because the specialist services already exist in Khayelitsha and in Mitchells Plain. Chairperson, I hope that is clear. And we did previously explain it, but that is the explanation to Member Van Vogel. And then secondly, in terms of the transitional care policy and starting the service, I think Mr. K made it very clear. There are, let's call it contract positions that is funded from a specific source for a specific purpose. That is what's been articulated to the staff, to say that because you were employed in that intermediate care facility in Brackengate and in Soornstra, specifically for the care of COVID as a transitional care activity, that contract comes to an end because the funding source comes to an end, because we now have to, from the 1st of April, manage COVID like any other condition in our normal service. But we're starting a service to say that's a non-COVID transitional care service. We therefore have to follow our own HR policy, which says you don't just switch over from a contract when the contract was for a specific purpose, that comes to an end, and you start the service for a new service that you don't go through a recruitment selection process. Then we are in conflict of our own internal HR policy. That's why we're going through it, because of our HR policy, and that we are not caught in terms of that. But what we're doing is we're allowing maximum opportunity for people to go through the recruitment selection process, which is a fair process. If they are successful, they will be part of a service and it will be a permanent position. So, Chairperson, that is the explanation. I apologize if it wasn't clear the first time around. Thank you very much.
Thank you, Dr. Kluter. Members, we will then move on. We will next do pages 3. Member Barnes?
Yes, my hand has also been up, Chair, for a follow-up.
I'm sorry, I didn't see it. There's something amiss here. I don't know what's wrong, but thanks. You may proceed.
Okay, Chair. My follow-up is on what Member Van Vogel was asking earlier, and the HOD is correct. We got that explanation last year already. However, Chair, one cannot help but to ask this one. Do we need that ICU bed? We do need that ICU bed in Khayelitsha or even in Mitchell's Plain. Why is that not happening, Chair? And also, attached with that, Chair, one can see the delays happening for the GF Chooster. Is it because of the explanation that we got from the HOD saying that these specialties are already with KDH or with Mitchell's Plain? And that's why maybe we are delaying to get the GF Chooster to get to a position where it becomes operational. I just think that maybe one should be enlightened more because we are not on the same level of understanding the medical terms. And at the end of the day, we have visited the GF Chooster facility, the former one, and we have seen that progress there is also slow. So maybe is it because of this explanation, or what is it really about, Chair? I would just love to get a feeling on that one. Thank you, Chair.
Thank you, Mr. Barnes. Dr. Kluter, before you respond, Member Van Vogel, your hand is up.
It's a legacy and Chair.
Thank you. Dr. Kluter, please.
Can I just chip in, Chair?
Minister, you're welcome. Sorry, Doctor.
Yes. No, sorry. Some of the other questions, I can understand the members. When they keep on asking the same questions, when we find that when they go on the ground, they don't see much the difference in as much as that we will have responded to. So I understand that part, but generally, most of the questions are the questions that we've been asked as many times. But I just want to chip in on this one now, the last one, about how to convert. On the part of the ICU, if the members will recall, when we were planning beds for the COVID, we even have to add beds through negotiations that were coming from the private. I think it was 300 or something. The high care beds in preparation for the COVID at the time, because not only in the province, not only in South Africa, internationally, a public service will never have enough beds for the high care, because it's not only expensive, but it's about you need the highly specialized specialists to be able to do so. So therefore, in anyhow, you'll never be able to have enough of those. But again, looking in terms of what is the driving force in terms of the service pressures in Khayelitsha, I think Dr. Kluter did mention the socioeconomic ills. Otherwise, we've got a high burden of interpersonal violence. So instead of trying to mop the floor, putting more people in the ICU, actually we won't even get most of the ICU staff. But the issue is about how do we tackle the violence? Why that you ended up having many people coming with all sorts of form of violence, blunt instruments, gunshots, pregnant women coming in the second trimester being assaulted at 2 a.m. and so forth. Why are we having such? It means that somewhere else, someone needs to close the tap. And closing the tap, it needs the whole of society. It cannot be only health. We are absorbing these. The reason that we are the ones who step up to a violence prevention unit is because it's us who feel that kind of a pain. So, and also looking at that with a blunt instrument and head injury, you also look in terms of the protocols. It's a clinical protocols, how to manage those. We'll find that if they meet a certain criteria in regard to the head injury in terms of responding, being responsive and whatever, all of those, where some of their actions, I don't know how I can put it, because I don't want to use the medical terms, where we'll find that there are those where we'll find that you can't even put them and maintain them in a certain state of where they could be active for resuscitation. What does it mean in layman's language is that you end up having some of these mostly young men, they ended up being what we call cabbage. I'm putting inverted commas. It's a normal, it's a layman's terms that are being used where the person will find that is non-responsive. But the problem is about how would you ended up having so many of these mostly young people and everyone else when we could be able, as a whole of society, as a whole of the departments, which is what we are trying to do with the violence prevention unit, because within 24 hours, go there on the dashboard, which is now be able for public around about the end of day or something where public can able to access it, just like they access the TB dashboard, the COVID dashboard, and HIV dashboard. They could access this one later on. One can be able to see within 24 hours. This is so many cases of the trauma and how they've been beaten up, and also using the information also from the mortuary and regard that. So it doesn't make much of a difference if you keep on trying to mop the floor instead of doing the preventive and the promotive in tackling the social determinants of health. That's what we're trying to do in terms of even talking about the budgeting and so forth. Thank you, Chair.
Thank you, Doctor. Appreciation. Dr. Klute, do you wish to add anything?
Chairperson, yes, thank you. So, yeah, I'm very interested in Member Barnes just wanting clarity. So I would give her the clarity. So the first clarity is there is no underhanded information that we're withholding from Member Barnes or Member Van Vogel or anybody for that matter. So that assurance I can give them. So, delaying Klipfontein has got nothing to do with specialist service being at Mitchells Plain and Khayelitsha. It's completely unrelated. The issue about Khayelitsha and Mitchells Plain needing ICU beds, I think the minister has addressed that. And many other places we have 1 or 2 ICU beds. For the intense resources that you get into, the ability to save a whole lot of people, it's a very scarce and very short of the resource. And anyway, it makes sense, and we learned in COVID that you concentrate that into into places, especially if you can transport people to that. So from where I'm sitting, and that is, if you look at Khayelitsha and you look at Mitchells Plain, from access to specialist services that makes the biggest impact, those services exist in Mitchells Plain and Khayelitsha Hospital. It is exactly the same as any other regional hospital anywhere else in the country. And in terms of what you mitigate what a specialist hospital would do. So that's the point I'm making. We probably should talk about acute hospitals, whether acute hospital renders specialist services or not. And that's probably the convention we are going to move to, because these previous conventions of district hospital, regional hospitals, central hospitals, tertiary hospitals are starting to become outdated as we move forward in the complexity of what we render in these hospitals. But I can give the undertaking to Member Barnes, there's no link between the two things. And there's our explanation is our explanation. And we can understand that we need to continue to come back to this. Thank you very much, Chairperson.
Thank you, Dr. Klute. Member Van Vogel, your hand is still up. Thank you. Members and members of the public, I think before we move on, I think let's take a break and have some refreshments. It is now 3:20. Let's be back here at 3:35. In other words, 15 minutes from now. And I really request you to be here, be seated by 3:35, 25 to 4. Thank you very much. Sorry, the refreshments are in the members' lounge. It's right at the other end of this building. Thank you. Proceed with the program. Thank you. The next pages that we will deal with is at the top of page 234 from program, the program description, item 9 there, until page 245. That's correct. The bottom of page 245. Are there any questions from the members? Member Fry?
Thank you, Chair. I have a few questions on these pages. My first is on page 237, sub-program 2.7 nutrition, and then the breakdown on page 238. I note that there is a 8.78% decrease, or 5.7 million rand. That's a decrease in nutrition. Yeah, it's a difficult one because the financial constraints have been already outlined by Mr. K already, but I'm very concerned that we are not that we're cutting short on something that is so desperately needed. I have some experience of Tygerberg hospitals admitting of children, and the number one problem that we have with admission of children and some adults is nutrition or malnutrition. So I would like to know, what was the rationale of a nearly 9% decrease in nutrition? My next question is on page 241. EMS, program 3, EMS as a whole. I'm encouraged to see that it's a 1.03% increase, or 13.4 million. My question for that would be, how will it increase service delivery in terms of actual trips and ambulance services? And will there be provision made for escorts for ambulance services into areas that are considered high crime rate areas? And we've all heard of the instances of stoning or assaulting of ambulance and EMS personnel. Page 244. It's my favorite topic. Excuse me, mental health, program 4.3. I note the increase of 1.34%, or 14.6 million rand, to a total budget of 1.1 billion. Now, last year, I think it was September, we went on a unannounced visits to Blentergear and Valkenburg Psychiatric Hospital, and those hospitals outlined the fact that they desperately needed more resources. Now we're not gonna go through what resources are available, but I note the 1.43% increase. I'd like to know how would that be spent in the mental hospital system. And then my last question is also on page 244, program 4.4. And this is the big one, 71% increase due to new transitional care facilities allocated here, or 189 million rand. That's quite a big increase, and it's welcome, especially for the growing cases of substance abuse in our society, and the stress it's puts on the healthcare system. My question is, where and how many new transitional care facilities are going to be set up, and where will they be set up, and how will they be integrated into the broader mental health care ecosystem? Thank you.
Thank you, Member Fry. I recognize Member Windvogel and Member Barnes. Member Windvogel.
Thank you, Chairperson. Chair, my question is on page 237. The heading is with reference to the National Measles Campaign that will take place early in 2023, or took place in early in 2023. I just want to check with the department if they can just tell us more about the measles outbreak in the province and just provide updates on the immunization backlog in our province. Then secondly, Chair, if I can touch on the violence prevention unit, what can we get more details on this and progress made in establishing it? And what is the mandate and how many staff members have been recruited already? And when will it start functioning? And how will the 28 million allocated for the program be spent? Then lastly, Chair, on the on page page 248, policy developments.
Remember, Windvogel, we're not on 248 yet. If you can hold that
okay.
until the next round, thank you.
Thank you, Chair.
Thank you, Member Windvogel. Member Barnes.
Thank you, Chairperson. My question is on page 239 under the table 9.2.1, the compensation of employees. What are the reasons for the decrease in COE budget, and do we have a breakdown of categories that will be affected? My second question, Chair, will be on page 240. Under the changes of policy structure services, I heard Member Van Vogel also asking a question on this one, but I want to align myself by asking what is the number of attacks that have been recorded this year as well as last year? How is the department addressing these attacks? Isn't there any element of extortion involved in these attacks? And now my last one, Chair, will be on page 238 under table 9.2, Chair, the summary of payments and estimates, program 2, district health services. What are the reasons for the decreased budget, Chair, for the 4 sub-programs, and how will the decrease of the budget for the district hospital Western service delivery, is there such a possibility? Can we get a detailed breakdown of how much each district hospital will be allocated for this year? I thank you, Chair.
Thank you, Member Barnes. Member Windvogel, your hand is still up. Is that another question?
Chair.
Thank you. Dr. Klute, if you wish to respond. I don't know whether the Minister wishes to respond, but I suppose these are for Dr. Klute.
Thank you, Chairperson. I'm very happy to respond. So thank you to Member Fry and Member Van Vogel and Barnes. Okay, so Member Fry's questions on the nutrition reduction, just to clarify, what our department spend on nutritional products is not what you see in this budget line, 2.7, which is part of the DHS. And just to explain what lives under 2.7, this is where we have contracted work via NPOs with a specific nutrition focus. So this is specifically for breastfeeding support, and 1 or 2 other NPOs that does nutrition education. We must very clearly state that many years ago, this is more than 20 years ago, we used to provide nutrition supplementation from this item, but that moved on to DSD. There were soup kitchens, food guard, all of those things were moved to DSD. So we don't provide supplementation to communities. we use the DSD network of food supply. This is specifically for a group of NGOs to do nutrition education, and it specifically is related to what happens in each of the geographic areas. And what has happened is many of this nutrition alone funding for nutrition education has been incorporated into what other NGOs does. So the history was you would have an NGO only doing nutrition education, another NGO only doing TB support, another one doing home-based care. What we've done with our NPOs now, the ones that host our community-based workers, more and more, they're taking on a full package. So nutrition education has become part of what the NPOs does that actually has community care workers. So you just need to understand that this specific budget line is specifically only for NGOs that only does nutrition education, and that nutrition education has started being incorporated into all the other NGOs that we work with. So it's not actual supplementation. So I just want to clarify that. The second question that the member Fryer asked was about EMS. EMS, we've tried to protect that there's no cut in the services to EMS. And there is a big program underway in our EMS management themselves to look at streamlining the EMS operation. It's a very impressive process of streamlining. So one of the things that they're doing is, and me and Dr. Karim recently went on a call with him, is they're streamlining how the call taking and dispatching works in geographic areas. But what they've also found is that if you have a lot, there's certain times where you have a lot of calls coming, and the calls is more than the available ambulances. And it doesn't happen all the time, but when it happens, that's when the waiting time starts going up. So one of the things that they're working on, the team's working on, they're trying to streamline and make predictable pickups to be able to mitigate for those times. So for instance, if they know that they have to come to a health facility to pick somebody up and take them to another facility, instead of being called to the health facility every 20 minutes or randomly, they want to stagger that there will be an ambulance that will come at this time. Please make sure that somebody's available. They come at that time, they come at that time. And that's what they mean, the predictability. It helps them to plan that they have more resources available. So I'm just giving you two examples of how they're streamlining internally in EMS to improve their service offering that will be coming in the coming months at 2 a year. The third question that you're asking is about specifically about psychiatric hospitals, the 1.34% increase on page 244 in psych hospitals. Just again to clarify, this money is specifically for 4 places. It is Lentegeur, it is Valkenburg, it is Stikland, and it's Alexandra. Across the 4, there are different types of activities that are funded in each of those areas, in each of the hospitals. It's not only acute psychiatry. They do other types of work as well. So what we're doing with this increase in resource is also to look at how do we streamline what they do across the other activities so that more money is freed up or more resources is freed up for them to be able to deal with the acute psychiatry load so that they can take the pressure of the district hospitals. So a lot of the resource that we have in our system that is increased for mental health is not in the psych hospitals, it's elsewhere to also cope with what happens in 72-hour at the district hospitals, but also to cope in community settings to maintain a mental health. But on the psych hospitals, those 4 hospitals, there is a removing of resources between the different components of what they do. And in the acute psychiatric care that they do is also to stagger their care, ironically, into acute short stay and then to transitional and back into community. But that is also a plan underway. And Dr. Karim and his team is very much on top of that. Your last question, which is on program 4.4, is just to clarify, when we say transitional care facilities, we are not talking about substance abuse facilities. Substance abuse facilities are rendered by the Department of DSD, Social Development, and we work closely with them. And also in Stikland, there's a specialized unit for that. But the transitional care facilities we're talking about under this agenda item is specifically Brackengate, Soonstraal. That is the places that we're bringing online in terms of this. So this increase in the budget line is because we created the budget line to bring those facilities into the services. We've had a bit of discussion about both Brackengate and Soonstraal, but the big issue that they will bring, and this is what we learned in COVID. We coped with COVID because Brackengate and Soonstraal and places like these could take cases out of the acute hospitals, out of Tygerberg, out of Grootske, out of this, out of Mitchells Plain, out of Khayelitsha, so they can cope better. So what we're doing is, this is medical patients that after they've been seen in, say, Khayelitsha or Mitchells Plain, and they've been there for a day or two and they're a little bit more stable, they can go to a transitional care facility, which takes the pressure of a place like Khayelitsha and Mitchells Plain. Now, we already have a place like that, and that is on the Lentegeur premises, which is called Aquarius. So this, of what we bring you on Brackengate and Soonstraal, is additional capacity. Brackengate will primarily take pressure of Tygerberg Hospital and of Karl Bremer Hospital. And you can imagine that the pressure in Tygerberg Hospital and Karl Bremer Hospital is quite big. So it will take off, like Aquarius is currently taking pressure of Mitchells Plain and of Khayelitsha. But Brackengate will also play a role of helping in that Khayelitsha access as well, of taking pressure off. So just to give you that context, Soonstraal obviously for Paarl and the West Coast, but the idea is that these facilities will be quite crucial because it will start taking pressure off the patients that is in the hospitals, in those big hospitals, and take the pressure off so that there's more throughput of patients in those facilities. Remember, Windvogel, yes, the measles campaign, just to clarify, the measles mass vaccination campaign from National is in response to measles outbreaks across the country. It's been in 5 provinces before outbreak was declared in the Western Cape. And just to clarify, the outbreak in the Western Cape was really of limited, isolated cases. So we did not have the type of outbreak that was in the northern provinces. We had 4 or 5 cases in the space of a week, but it was far apart. They were not linked. And technically, it was declared an outbreak, but it wasn't actually an outbreak in the local neighborhood where there was a lot of cases of measles from one area. So, but we participated, like everybody else in the country, with a mass vaccination campaign. So what normally happens is with measles, part of the international process is you need to keep your routine vaccination up to a certain level. So we aim to keep it as close to 90% as possible. In COVID, we maintained it just below 90%. It dropped to about 88%. But we were concerned about measles vaccination not being as high as it should be. And we're trying to push it with routine vaccinations above 90% again. But every 5 years, you're supposed to do a mass campaign just for all the babies that might have fallen out over the 5 years. And that's why a measles vaccination campaign is always almost for a child up to the ages of 5 years. And this case, probably also higher because it is into the school-going age as well. So when you do it for all the children up to the age of 15. And that's where you ask for consented schools and all of those. So the point that we're doing quite well at the moment, our teams are out there working with the under 5s, working with school-going children, and vaccinations are running quite smoothly in terms of the province. But the question you're asking, our routine vaccination has dropped slightly below 90%. Our efforts is to get our routine vaccination for children under 1 back up to above 90, and that's when you maintain protection. The campaign is for all children up to 15. It's a boost once every 5 years. We're doing it now. We are progressing well, but after that, we will continue to do our routine above 90% to protect the most vulnerable children. In terms of the virus prevention unit, the detail is that a new structure has been created. I'm going to ask Dr. Karim just to give a little bit more detail on that structure in terms of the violence prevention unit. But we've just received the approval from the DPSA, so we can now move to actually advertise the posts. And we are hoping to fill those posts very quickly so that we have a fully functional violence prevention unit in the shortest possible time. In terms of its mandate, it will have 3 key broad areas that it will perform. The first one is it will advise on all data and evidence-related things around violence prevention. So as I explained earlier, it will find all the data and all the evidence to say, if you do these things, this is how you are going to prevent violence. So we'll get it from international best practice, from local researchers, and we will work with the researchers and will tell us, these are all the evidence-based informed processes and things that we have to do. And this is what we have to do to be able to curb violence. So its first task is a evidence data function. The second function that it has is a policy formulation function. So this is a function where if we are not doing things that we're supposed to do, we then need to adopt new policies, and we can do things differently to help us. For instance, around parenting programs, we know the data says that if you assist a young mother with parenting of a children, you reduce the vulnerability of that child to violence when they're older, but you also reduce the probability that they will become a perpetrator of violence. So parenting becomes very important, but we need to look at what is our current policy process around parenting and how do we incorporate it into how we do business around that. So that's just an example of that. But the third function is probably the most one that's going to be have the biggest reach. The third function, and that's the biggest of the resources in the violence prevention unit, is actual additional people that we will deploy in local geographic areas. And they would be called area-based team conveners. So they will help local teams to get together, to make local connections between education, health, DSD, the police, the law enforcement, the municipality, with community watchers, with neighborhood watchers, and start localized.
Dr. Kluter, we've lost the connection there, or at least the audio.
My apologies, Chairperson, was I broken off?
Yes, you are back with us. Thank you.
Thank you. So the last function is area-based team support, and that will be more detailed support in each localized area, and it will be in all the prioritized areas of high hotspot. We're actually having a session tomorrow where we are finalizing exactly what will happen in each of those local area-based teams across the different sectors. And from the 1st of April, we will be actively making sure that each of that local teams are functioning and coming together using the data and the evidence for local programs to prevent violence. Member Barnes, I will again ask that the compensation reduction that you referred to, that Mr. K just quickly touch on that compensation reduction in the table on page 239. Just on 240, the tax on EMS, my response is that obviously the tax on EMS is something that we are strongly condemning. The tax have stabilized over the years, so the numbers are maybe staying more or less even. And there's still the red zones. We're working more and more with our teams to create what is called safe corridors. So more and more we're working with local community structures, we're working with CPFs so that we can create a little bit better access, because even our own EMS guys are saying the red zones, and for them having to wait for police to accompany them, delays them getting to patients. So we're finding creative ways of navigating through that. There's been no evidence to say that any of the attacks that's come has been extortion related. These are pretty much every incident we've had as it's almost incidental criminal acts that has come through that. And then the last question that you asked is on page 238, the reason for the decrease. If you take on page 238 all the issues related to the district health program, right? So you have asked, there's a 1.49 for community-based services, a 1.1 for HIV, 8.7, which I already explained to Member Fry around nutrition, and a 6.2 for district hospitals. And you're asking the main reason for that. The main reason for that is the removal and the reduction of the national conditional grant, specifically for COVID and for vaccination. So that is the effect that you're seeing, that the resource has been taken out. And that's the main reason why that's reduction is in those areas. And I think we have started saying how we are mitigating against those specific regions. So from a district hospital perspective, what we are taking away there is the buffer that COVID additional posts did give people. And now we've had to look at internally, how do we buffer, and working with that specific post that is now not there, that people were supposed to be for COVID, but actually because COVID, they used them for other activities in the hospital. That is the reality in most of our hospitals across the province. So it's 3 people here, 4 people there, 5 people there. It's across the province. And it's really about mitigating. How do we work with the staffing that we do have to be able to mitigate against the additional hands that would be felt in those specific areas. Chairperson, I'm going to stop there. I'm just going to ask just Dr. Karim just to very briefly say how many exactly the numbers of people in the violence prevention unit, and then Mr. K just to talk about the compensation reduction, which he touched on earlier as well. Thank you, Chairperson.
Thank you, Dr. Glitter. Dr. K.
Thank you, Chairperson. So the violence prevention unit will have a total of 16 posts. 9 of those 16 posts, in fact, what Dr. Kluti is talking about, are the area-based coordinators. So the majority of the posts there would be to help coordinate across the different areas, the different area-based teams. And we're quite excited to begin the recruitment and selection process of the 16 posts. The other posts are administrative posts. There's a public health specialist post in there as well, and there's 2 coordinator posts at head office as well. But the majority posts are for the area-based team coordinators at the local level. Yeah, thanks, Chair.
Sorry, thank you, Dr. Karim. Members, any further questions? Mr. K, do you wish to add?
I was delegated one question to
Please
answer.
proceed.
Thank
Please
you, Chair.
proceed.
And I pray forgiveness because I want to refer to page 259, which details the personnel headcounts by year, by program. And you will see in the district health services, we are decreasing from around about 13,888 down to 13,411. And that is articulated earlier in the impact of the removal of the COVID funding, because it's a district health service related program. So that's the details. Thank you, Chair.
Thank you for that, Mr. K. Any further questions?
Mine is more follow-up, Chairperson.
Councillor Windvogel, Member Windvogel.
Thank you, Chair. Chair, my follow-up is on the EMS. I just want to check with the department. As we all know, there is a shortage of ambulances and personnel. I just want to check with the department, what are the plans to increase these? Thank you, Chair.
Thank you, Member Windvogel. Dr. Kluter.
Thank you very much, Chairperson. Just for Member Windvogel. So there are 2 types of plans, Member Windvogel. The first one is we're looking at our fleet of ambulances. We're looking at the repairs. We're looking at getting the right fleet on the road. Good progress is being made to take non-functional ambulances out of the fleet and getting new ones and fixing old ones so that we have good fleet on the road. That's the one aspect. The second one is working with our staff, our personnel. Now, there's a big number of personnel amongst our staff that has suffered post-traumatic stress, that has been with us, that have had the episodes of having had multiple times being held up or robbed or whatever, and has been receiving employee assistance. So we have a very clear process of working with the staff and if need to be, either fully, people are fully recovered, or if they're not recovered, relocating them somewhere else to work in a different part of the department. And we've actively started that program so that we create space for active people on the personnel. But obviously, you can understand, we have to do it with compassion, in counseling with our staff, in consultation, and there's a big commitment to actually start moving. So as we get more vehicles, we also have more staff to be able to be on the vehicles as requested. Thank you, Chairperson.
Thank you, Doctor. Members, if there are no further questions, I think we do the last stretch, and we will go then from the top of page 246, which is program 5, till the bottom of page 260. If I can have an indication whether there are questions from the members on the floor or in the chamber. Are there questions online? I see Member Windvogel's hand. Member Windvogel, please proceed.
Thank you, Chairperson. My question is, Chair, on page 248, policy developments. I just want to check with regards to the Western Cape College of Nursing accreditation from the Council on Higher Education. When was the full accreditation received, and what are the updates on enrollments? And how will this affect the issuing of bursaries? And will the students be forced to study at this college? Then secondly, Chair, my second question is on page 254, page 254, health facilities management. With regards to those facilities that were integrated from the city, are there any infrastructure projects that are planned? And whose responsibility is it to ensure that all clinics have waiting areas for patients queuing outside facilities from the early hours? And how much of this budget is earmarked for that? Then lastly, Chair, my last question is on the issue of payments and estimates by economic classification. What are the reasons for the high increase on budget for communication, legal costs, entertainment, operations, lease, and travel and substances? Now, as we always complain, we don't have a budget, and there's...
Member Windvogel, we've lost you. Member Windvogel. Member Barnes, I will move on to you until we get Member Windvogel back. Member Barnes. Member Barnes. Member Barnes. I don't know where these members are dialing in from. It's possible that there's, what time is it now? It's just over 10. So had there been load shedding, it would have been on the hour and not now. Members Windvogel and Member Barnes, can you hear us? Are you with us? Member Barnes? I'm going to ask Dr. Klute to respond to the questions that have been asked until we get Members Barnes and Windvogel back with us. Well, they're not going to hear, but at least we will have the recording. But
thank you very much, Chairperson. So, yeah, thank you to the questions of Member Windvogel, the first two that I could follow. The first one about the Western Cape College of Nursing accreditation. It's something that we are extremely proud of. The Western Cape College of Nursing is the first public sector nursing college that has got accreditation as a higher education institution. So with the accreditation, what it means is that we are now offering in the Western Cape College of Nursing the equivalent of what is being offered in other higher education institutions for nursing. The automatic question And we also got accreditation for all the programs that we can offer, including some postgraduate programs as well, which we're extremely proud of. The question that Member Windvogel actually is asking is, what does it mean for bursaries, and what does it mean for people wanting to study that has bursaries? Will they be forced to choose this as opposed to others? Just the assurance is we have a multilateral governance structure with the universities. And we've been meeting, there's a multilateral agreement between us and the universities. The minister chairs a governance structure with all the vice chancellors and herself once a year. I chair a meeting with the deans between the 4 universities and us every quarter. And there's a very, very, very clear understanding that we work collaboratively in this province between the universities and ourselves. And this matter of the status of Western Cape College of Nursing as a higher education institution, together with other higher institutions like UWC, CPUT, Stellenbosch, and UCT, there is a very clear mechanism that's put in place. Dr. Karim actually oversaw it, and now the colleagues are meeting regularly themselves, that there is combined planning, there is combined allocation. Students have the freedom to apply and to choose where they want to choose. Our bursary system has got nothing to do whether you're at the Western Cape College of Nursing student or not. It is bursaries applies to everyone, irrespective of which HEI they attend. It's basically given on need. And then secondly, for students to have placement on the healthcare platform, there's no skewing or preference for Western Cape College Nursing as opposed to other nursing programs in the province. And all the HEIs and us monitor this jointly, and there is a very good collaborative cooperation, which I can give the members assurance of in terms of fairness, in terms of what's happening with that. Then in terms of a second question about city facilities and then waiting areas, just to indicate that in terms of the city facilities that has been moved over to us and we've assumed responsibility, there's a process that Dr. Angeletti de Toey and her team goes through Public Works in terms of ownership of the facilities. So there is still a process about whether the facility then gets moved to our transfer and gets transferred to us. Once it belongs to us, then we take responsibility for the maintenance of the facility. That is in process for the 10 facilities for which we've assumed the responsibility. But then also, in addition to that, the question that she then asked is whose responsibility is it for waiting areas for people where people come in early and the weather must be of such a nature that people have to wait outside in the rain. Now, what we have, facility by facility, there's a different, all our new facilities is built with a waiting area and a protection roof. All our new facilities is built like that. Now, we have a lot of existing facilities where we also then say with our maintenance money, we want to create a waiting or little waiting area where there's some protection. But some of our facilities are built in such a nature that it's right on the street and it becomes municipal because we have to get municipal permission to put that up. So per area, each of our areas per district has prioritized which areas we want to add waiting areas ourselves. Secondly, which areas do we want to negotiate with the municipality in terms of erecting appropriate structures for waiting. So there's a complete prioritization list across the whole province, and it's built into our resources for our maintenance resources to have that as a project across the province. Those are the questions that I could follow. The last question, Member Windvogel, was cut off, Chairperson, and I couldn't quite follow what was in relation to. Thank you.
Thank you, Doctor. Member Windvogel is back with us. Member Windvogel, do you wish to repeat your third question, please?
Thank you, Chair. Chair, my last question was on 262, table 82. I just want to know what are the reasons for the high increase on budget for communication, legal costs, entertainment, and operating leases and travel and substance. So because we know we are struggling in terms of our budget, we always complain there's no money, but we do have huge increase on these items. If the department can explain to us why.
Thank you, Member Van Vogel. I see Mr. Dr. Kluter, before you respond to that, Member Barnes, you have questions?
Yes, Chair, only two questions. The one is on page 251 under the medical depot, the plans that are underway to replace the current Cape Medical Depot in Chipiani Street. Chair, what I would want to know here is that what necessitated this move and what are the costs associated with it and when will it be completed? That's my first question, Chair. My second question will be on page 252 under table 9.7 laundry services. What are the reasons for the decrease of this budget, Chair? If I can just get a response on those two. Thank you, Chair.
Thank you. Dr. Kluter, I don't know whether you wish to respond to laundry services, but over to you.
Thank you very much, Chairperson. Thank you, Member Van Vogel. So I'm clear about the question. So that Member Van Vogel is talking about 262. I'm going to just ask Mr. K or Mr. Carrick if they can just quickly indicate those increases. So we need to understand that when we talk about the communication, when we talk about catering, so for entertainment, for instance, we're talking about 270,000. And then if we're talking about, I'm not sure, I've called that too, there's legal cost as well. So I will ask just Mr. Carrick, maybe there must be an explanation of why those have increased. And I know that there's a technical explanation for those amounts. There might be other things on that table, but if Mr. Carrick can answer that first one. Then the second one around the Cape Medical Depot for Member Barnes. Yes, so firstly, Member Barnes, the building, and we've done an evaluation many, many years ago. The building is not in such a state that it is state of the art and what we require. And it has always been that we need to find a new building that can be much better space, warehouse, and all of that. So the building in Chapini Street is not ideal for it. We have been looking for a long time, and we've now secured the ability to do it at Tygerberg. I'm going to ask Dr. Angeletti Tutwe just to give you feedback of what the progress is, where exactly we are with the Cape Medical Depot. And while Dr. Tutwe is busy with that, Chairperson, she can also give you the answer of why there's been a reduction in the laundry. It's also a technical reason, but I will ask her to do both of that. So, Chairperson, if you don't mind, if Mr. Carrick can deal with the first table, and then Dr. Angeletti Tutwe with the last two issues. Thank you.
Thank you, Dr. Kluter. Mr. Carrick.
Thank you, Chair. Okay, so just a point of clarification. If we look at communication, my comparison would be to look at the adjusted appropriation amount, which was 63.4 million for 22-23. This has increased to 65.5 million for the 23-24 year, which is a reasonable increase. I'm getting a roughly about 2.5%. So I'm not sure if they're being confused by the revised estimate column.
Yeah, that's the reason. Just explain the technicality difference between the two. Yeah.
It's a requirement from Treasury, that column, and I believe it's got something, but my technical guys will explain it better. It has to do with possibly a projection or something. I will be guessing, Dr. Kluter, but because I always work with
appropriation,
the adjusted budget, because that's the most recent budget that we had and closest to the most realistic budget of the previous financial year to the current year. I'm happy to go with the others because I can give explanations. So legal costs 17 million to 21 million. Just to put this in perspective, a lot of this legal costs would be spent on defending our medical legal claims. And this is money well spent, as if you had to compare our payouts compared to the other provinces, it is significantly less. We are under pressure in this area. The amount of claims are significant. We are fortunate to have a very strong medico-legal team that assesses all these claims on a reasonable basis, and where need be, they will then go out through the state attorney to get additional support from advocates to assist us in our fight against some of these claims, to bring it down, not necessarily to totally reject it, but just to get the claim to a more reasonable amount. So that would be on legal cost. Entertainment, it actually decreased from 277 to 272,000. It is a very small amount, and this is an adjusted appropriation. I haven't actually checked what the actual figures was. We were busy finalizing our year, but we very rarely spend that budget, and it is a very immaterial amount in the greater scheme of things. And then finally, travel and subsistence. Yes, so my only, it's there again, it's 70 million versus 66 million. My comment here would be that one of the benefits out of COVID is that we have adjusted the way we operate using technology like Teams and that. We are, so the travel from the COVID period reduced to almost to a very minimal amount. But we now, as we're coming back into more normalcy, there is a need for travel for nurses, healthcare workers, and that to travel out into the regions. From my finance perspective, I have teams of people to go there and do compliance testing and so on. The human resources also do perform testing. So once again, it is. I would say quite a reasonable amount in terms of the greater schemes of the budget. I hope that answers your question.
Thank you very much, Mr. Carrick. So, Chairperson, it is just that technicality of the change of percentage against revised estimates as against to the final appropriation. And that is what gives those like erroneous high percentages. That's the first thing. And then it's obviously these amounts are quite reasonable in terms of the overall operations of the department. Thank you, Chairperson. Dr. Angeletta du Toit.
Thank you very much. And yes, I will answer first to the question about laundry service and the reduction. We had an outsourced contract to deal with the COVID linen. So this contract is ending at the end of May, if I remember correctly. So that is why we will not need additional resources, because we had quite a big increase of utilization of linen during the COVID period. In relation to the other project, the medical depot, as Dr. Clutie mentioned, the building where the current building is, the current function is on different floors. So you can imagine it's not suitable to be a warehouse. So the warehouse should be on one floor, and this is what we are planning. The project is at a complete concept design. So we call it, the high-level design has been completed together with the pharmaceutical directorate. It's a quite interesting logistic warehouse that we are going to build. And we are planning to go out to tender for the design and construction in the course of the next financial year, because the idea is to get a contractor that is familiar with the warehouse, like is happening all over in the Western Cape, and then the construction can proceed quite rapidly. The total cost of the project is around about 250 million, and it's quite a big building, and will be located close to the No Pharma warehouse at Takeber Hospital. Thank you.
Thank you, Dr. Angeletta. Thank you, Chairperson.
Thank you, Dr. Clutie and Dr. Angeletta du Toit. Appreciation for that, and also to Mr. Kay. Member Barnes, I see your hand is up.
Apologies for that one, Chair.
Thank you. Members, then for the last time, any further questions on the last portion of the budget report? There seems to be none. In that case, I'm going to give the opportunity to the members of the public to put questions to the department. Can I have an indication of people who would like to ask questions? There are 2 questions or 2 hands to my immediate left. Please, when you put your question, switch on the mic, state your name and who you represent. Again, we know that who you represent, but for the record, and put your question. I recognize, sorry for that. I also see the hand of Ms. Lake online. Thank you. Please proceed, lady.
Thank you, Chairperson, for the opportunity granted to us as community members. So I'm Damaris Kiewicz, and I'm the Chairperson of the Cape Metropolitan Health Forum. For the record, it's our 25th sitting of the budget for the Department of Health. 14 years under the leadership of the DA with lots of challenges, but we won't go there. My question is, I've got a few questions, and that is both for the Minister and Dr. Klute. When they say they need to make difficult choices of service provision for the poorest of the poor, now we already see the challenges. Who is the poorest of the poor? Is it the person that has an accident on the R27 with the medical aid, or is it the person that has an accident on the R27 without the medical aid? Because currently, what we see is that services are not provided equitably and equally for the differentiation of where it happens. So that will be my first question. Then my second question is on page 221, where the Department of Health and Wellness says, we undertake to provide equitable access to quality health services in partnership with the relevant stakeholders. Who is these stakeholders? How are they identified? And are they part of the engagement when it comes to the Department of Health? Then, and I didn't get the page, but it's around child health. I think for the Portfolio Committee, we have raised the question around community IMCI. That's Community Integrated Management of Childhood Illnesses for children under 5. Now, if we see what is given to community-based services, are the services for children under 5 included in that service? Because currently we don't see it happening. We still see children suffering from malnutrition. We still see children with stunt growth. And if the community IMCI program is in place, then we would see an elimination thereof. So if the department can respond to that. And then the 2-month salary budget that the department is going to allocate for Brackengate and whoever other one, where will this money come from if the department say they don't have the money? Are they going to rob somewhere to pay somewhere else? It's just my concern because they said they're going to do 2 months. Then my last question is the ICAS budget for staff wellness. I don't see a clear indication for that. If we could possibly know who provides the ICAS service in the province and what is the budget allocation therefore. Thank you.
Thank you. The gentleman next to the lady.
Thank you, Chair. Thank you for the opportunity to can ask this question. My name is Graham Lindos. I'm the chairperson of the Tygerberg Sub-District Health Forum. My question is around the EMS staff and the vehicle that usually goes to the police station, because that is impacting on the service that they need to deliver, because these vehicles stand close to an hour at the police station before they get escorted, because the police's mandate, core mandate, is not escorting of these vehicles. Now, in the Bishop Lavis area, where I'm also the chairperson of the CPF, we have a very good relationship with especially Mr. Newman and his team, where we then came up with a solution and said, we will identify in each sector in our precinct people or a person that will coordinate whenever a vehicle needs to come into the area so that they don't need to go to the police station. They call that coordinator activates neighborhood watch staff within the area. And we've done that last year already. The problem is we are told that policy don't allow them to do that as now. In the meantime, while policy is not allowing it, our people are waiting for services for an hour and it's emergency service. Is there nothing that the department can do if they are serious about service delivery to do something about the policy? In this case, where a community says, man, if there's a red zone area in our area, we are willing to assist whatever time of the day or night it is. But the policy just needs to be changed, please. That's the question from our side.
Thank you. Any more questions from the floor?
Christina Nomdu, Western Cape Commissioner for Children. My question is whether the department would be willing to engage the children in the Commissioner's office to make this budget more child-friendly, more understandable, and to give us the opportunity to talk with each other and make a submission to the department on our views on children services and the budget. So whether the department will work with us on that process.
Thank you for that question. Ms. Lake, online, if you would like to put your question.
Thank you very much. I'm speaking on behalf of the Child Health Priorities Association, who issued a preemptive call on the 1st of February, raising concerns about the potential impact of austerity budgets on child health. And that call to action was endorsed by over 20 organizations, 500 health professionals, and the Department of Pediatrics for 5 universities. So for this reason, we're really concerned about the contraction of the broader Western Cape health budget for this current year, particularly if we factor in things like inflation and the very high inflationary pressures on the costs of medicine and equipment, together with the rise in the population, which again puts additional pressure on services. So when we took a look at your budget, the first question we were asking is, where are the children? And of course, it's very difficult to see where children fit within the way the budget is currently structured. So I would like to support the Children's Commissioner's call to develop a more child-centred and child-friendly budget where it becomes possible to disaggregate services that are provided for children, to make them visible, and so that we can then assess this budget to establish its impact on children and child health services. So that's the first point I wanted to raise. And then I have 3 specific questions. Just give me a moment to open them up. So on page 223, you call for the reprioritization of services within the district health services platform. And that's in relation to a contraction, I believe, in district health spending. We certainly welcome the department's focus on equity, which is especially needed in this time of austerity. But the question we wanted to pose to the HOD and MEC was, what measures are you putting in place to prioritise child and adolescent health services? There are very strong arguments for ring fencing and safeguarding child health services, and very clear guidance, in fact, from the UN Committee on the Rights of the Child that there should be no retrogressive measures, that even in a time of economic crisis, we need to ensure that children's services are prioritised. And that if there are any regressive measures introduced, that only happens after all other avenues have been explored and where children are the very last to be affected. This, of course, is particularly pressing in the context of rising food and fuel prices, which are compromising, as many of the honourable members have mentioned, children's nutrition, but also their ability to afford to travel to healthcare services and therefore their compliance with medical treatment. Plus, we've also seen how COVID-19 severely disrupted routine child health services. And in fact, resources were diverted from child health to support adult COVID care. And we haven't necessarily seen a significant or sufficient improvement in the under 5 primary healthcare utilisation rate. And we're still seeing suboptimal coverage of key child health services such as immunisation. So the first question or second question is really what specific measures are the MEC and HOD putting in place to safeguard child health and child health services at a time where both families and the healthcare service itself is under increasing pressure and strain. Question 2 refers to page 233, where you speak to additional funding being allocated to mental health services in the Western Cape. Again, we would like to know how much of this budget has been allocated to strengthen child and adolescent mental health services, given that 1 in 10 children in South Africa have a diagnosable and treatable mental disorder, yet only 1 in 10 of those children are actually able to access health care. And especially given that 50% of all adult mental disorders have their onset before the age of 14. So would it be possible to disaggregate that line item so that we can make explicit the spending on child and adolescent mental health services? And then question 3, again, focused on page 233. We are pleased to see that there is an allocation to nutrition. Especially as we know that 1 in 5 children under 2 are stunted in the Western Cape, and that is a sign of chronic malnutrition that impacts on children's immunity, increases their likelihood of childhood illnesses, as well as their risk for NCDs, non-communicable diseases later in life. And we also know how stunting is not just stunting the physical body, it's stunting the developing brain in ways that impact on children's education and employment prospects across the life course. So nutrition is of growing concern this year. In the context of rising food prices, we're looking at food price inflation standing at roughly 13%, a child support grant that is falling way below the food poverty line, and anecdotal evidence of children being admitted with more severe and extreme forms of malnutrition. So the question is whether the budget allocated to nutrition is adequate to address this challenge, and for the HOD to hopefully clarify how are nutrition services for children funded in the province and which line items are implicated. Thank you very much.
Thank you, Dr. Lake. I'm so pleased I don't have to answer that. Dr. Klute.
I'm very happy to answer it.
Can I start to answer first?
Please, Minister, please. Sorry, Dr. Klute. Minister, please proceed.
Okay. In regard to that, who are the stakeholders? I think Dr. Klute made, when he started with the preamble in the opening statement, he repeatedly spoke about health is everybody's business. Because it means that we shouldn't only be looking in regard to what is happening at a health facility, because the health system, like everybody knows, including Umama Damaris Kivitz, is about it happens also outside a health facility. Part of the primary health care, it talks about the home-based care. It talks about the intersectoral collaboration, where you need every stakeholder from the civil society, faith-based organizations, business, and everyone to participate in the health space. So when you ask who is a stakeholder, everyone should be a stakeholder
because it's everybody's business, and also to see in regard how if anyone could be able to participate. For example, in the standing committee, it's also their role to be the voice of the department or the voice of the community to fight for extra budget from the national level in regard, like we have put it there, that our budget has decreased by
Minister, we've lost you.
about 1.5 billion and so forth.
Okay.
Therefore, actually do it on behalf of Antisaras of these provinces about the sector. We also may talk about 75%, but you go in the deep rural areas, like where I'm coming from, in the Matsikama, today, in the Matsikama, just pinpoint one private hospital. There's no private hospital. So if you are a billionaire there, you're still going to be using our facilities. I think similar with the Beaufort West and other areas outside the metro. And therefore, it means that anyone else will end up coming. In the metro, for example, just making an example of an area like a Hout Bay. Hout Bay, you have got that three kind of areas. We've got the valley, where you'll find that is the most people who have got the haves. And then we've got the other ends, which is the Hangberg and the Mizamoyedi, to where they are the have-nots. In as much as that, you'll find that you've got these communities, you might make an assumption that in the valley, which is where the haves, that they are only relying on the private. But you forget that they are older persons, specifically most of them are women, older persons who are on chronic medication, who still has to come and fetch their medications, or also being assessed within the public spaces. Other chronic conditions like TB, where do people who have got medical aid to take their treatment from? For example, for the TB. I did indicate that there is no policy in health that says that we are full or we cannot be able to take you. And our prioritization in terms of that, who's the poorest, who's the what, our prioritization is based on the illness. So you might have, like, especially when you see in our ECs, you might get that person who might be actually maybe rich. We don't know. For us, we only see a patient who might be rich, but coming with a step heart. And then we have got Auntie Sarah with a 3-year-old who's very poor, probably maybe coming with a cough or whatever, pneumonia. And then when you do the triage assessment, you find that that rich person is a red. And then the other one, who's the poorest, probably is a yellow or a green. You prioritize according to the illness. So you may make an argument, that person should have gone to the private, but the person is already inside, inside is a patient. Therefore, you prioritize in order to save life and to improve the quality of life and to prevent the complications. In the issue of the equity, there are various ways that they are applying. Again, the issue of the rural versus the urban, and also the issue of the within the urban in regard to the haves and the have-nots. Just to make an example, in the sub-districts, which is for the metro, in regard to the sub-districts, you get a high level of personal personal violence and injuries in the areas of the Khayelitsha, because they've got more younger people. Whereas you might get, for example, in the Klepfontein side or in the southern side, where we have got a high level of the cardiovascular in regard to that. And the responses, and mostly the older persons, so the responses will be different in terms of how they're supposed to navigate in regard of the prioritization. So the issue about who's the stakeholder, anyone's a stakeholder from the community, for me, from my side at the political level, I always use the drip yenepoki in regard to understand how I'm to respond to a health system where the port is the health system. ENBN is about the health society, where the MPs, the MPLs, the councillors, and everyone have to play a role, especially outside the metro, where all health services are under the province, whereas at least in the metro there's a city. So you don't want to leave behind those mayors who are and also councillors, especially ward councillors, who are the first contact as a leader in that space for that anti-SARAs who are there. And the TULPN that talks about the civil society stroke the community, be it is a organized one, as according to the National Health Act in regard to clinical committees and the hospital board, and also generally especially for our partners in the community-oriented primary care, which is inclusive of the NGOs, and also other sectors and other departments like correctional service and so forth. And the DRJPN, which talks about us as government. When we talk about this as government, we also look in terms of orientating the people in that area about, we do have the EMS that are part of it. We do have the forensic pathologists that are part of it. We do have others, like in the higher education sector, that they are part of it and everything else. So for me, that's how we view the whole thing about the stakeholders and also who's who in this kind of a setting. I think the staff wellness, Dr. Cruz can answer that, but what I know that it's a transversal, that is the department of the Premier, where each department make a contribution in order for their staff to be able to access that service. And it's being renewed according to the tender in terms of which company that offers it. The last time I checked, it was the Metropolitan around that. Having said that, there is also within ourselves, especially during the COVID, where we look in terms of the occupational health broadly and bringing it at a local level so that you don't have to wait to go to the ICAS in order to access, for example, whether it's a counseling and so forth. Like one typical example is a Grooteskier Wellness Center for the whole staff, where it's not only about to access for the counseling any other time, but also in terms of going for the exercise, they're looking at the wellness broadly, environmental wellness, financial wellness, and so forth. And also we'll find that now, even with the Western Cape on Wellness, wow, we've got some of the WAMP champions within different other hospitals where we'll find that they could be able to do the whole thing about the wellness within their staff. Now, on the issue of the EMS, that in regard to the EMS and the escort, that's one of the things that I always say, that I don't know why we are always generally being the ones who are being sort of all the fingers are pointing to. Yet we are the ones who are the victims. Our job, our core job, is to render health service and save lives. It's not actually our main responsibility to militarize or to securitize. It should be other sectors, other people must make sure that we do our job in a safe environment. That I'll have to be driving, because there are normally two people in ambulance, that I'll be driving as a paramedic, going to fetch a patient that I'm supposed to save life and bring to a nearest facility, and then still I have to look around, I have to wait for an hour or so. That thing of that have to have an escort. And then even when you have got an escort, that you have to be waiting, and then you've got all of these calls that are coming in your monitor whilst you're in the car. And also by the time you go there, we have heard some of the staff actually find that it was actually a fake call. They end up robbing them. Probably maybe it's a drug addicts who are looking in terms of what would be the best way or quickest way in terms of getting access to all of those. It shouldn't be us who should be worried about that. As we are worried about our staff, our priority, because there are no healthcare, there's no health service without staff. That's why we go out of our way to protect our staff, where we say that this area has been identified by the police as a red zone. Therefore, no matter what, don't try to understand that the issues of the moral injury, where you feel like, no, I have to go because this is a really priority one. This woman or whatever is about to deliver, it's a complication and so forth. But because they would have said it's a red zone, meaning that you have to wait, but noting as a health professional myself, you are trained to save a life. When there are obstacles that are beyond your control, where you know what to do, and then you end up not being able to do it, Either be that you have to stay in the next to the police station, or you don't have equipment A, or find that people are howling and whatever at you when you're trying to save life. It does make a huge impact, not only in your morale, but deep down in your conscience. You always feel that I came to this profession as a calling. Some of us came as a calling, even if it doesn't show. Now, when you have got such kind of things, where you find that you are also being ridiculed or you don't have enough equipment, it does hurt you most. So we have got staff members where we find that it's not about that there was someone who pointed a gun at me trying to steal my phone, but the issue that I was on my way to save this baby and this happened. What kind of a person who will be on the way of saving a life? Unfortunately, we are working in a dysfunctional society. All the socio-economic determinants of health that are happening outside, they are beyond our control. So whatever way that the
Minister, you're breaking up.
Okay. Am I there now?
It's better now. Thank you.
Okay. So what is difficult to entertain is about, because not only in the EMS, there are others who say that, oh, you need we can help you to do most of the lots to follow up patients from TB or HIV ARVs. Will help you if you could give us ABC, so much amount. And then we say, we don't have the money. The money we have, the resources we have is about the rendering the service. It's everybody's business. If you could be able to do A, B, C, D, let's see how we can create an enabling environment for you. Not only you are helping us, you are helping the anti-SARAs. So as a clinic committee and as a health forum, for us, if you be able to make sure that if it's, I think they once started it, I think in Guguletu or Nosbele, where you'll find that at the time, they will know in terms of when the ambulance is coming, then they could be able to assist. But in other parts of the metro, not only the metro, also in the rural areas, the IFAs, they specifically in the rural areas where there is not even a network, where they'll give them the radios, some phones there, so that when the ambulance come, they are always the patient. They've already assisted to bring the patients, especially in the rural areas. So whatever way that you can assist, but what that is not doable, it cannot be done. It's about when we compromise the information, the confidentiality about the patient. When it's about where it's about what is it for us, how much you can be able to assist. Health is everybody's business. In regard to Commissioner about child and also dog, you mentioned about the whole thing about the child. I'm not laughing like I'm laughing. It's about one of the challenges that I always think the department and Dr. Kluti can also mention. Whilst we are focusing on the life approach, which is from the unborn, which is from the cradle to the grave. Remember, even the deceased, they are the patients. They are our patients for the unnatural death. Our focus is about throughout the life cycle, starting from the unborn. And then within the health sector space, you have got different disciplines. In medicine, I think, I'm not sure there are 8 or 9, where there will be psychiatry, there will be the pediatricians, there will be the ONGs, and so forth. And then we've got subspecialists, and then we've got super specialists. And then in the nursing, I think there are about 4 general in terms of the disciplines. But the point that I'm making, for example, at the time that I was a clinician working, my area was on sexual and reproductive health, plus also as a person who's got a qualification in maternal and child health. So wherever I go, I'll always be asking about what about the mummies, what about the babies, and what about the youth on family planning and all of those. And then we have got a colleague who have got a specialization in something else. They'll be saying that, what about the broken bones? What about the orthopedic? What about all of those? The point that I'm trying to make every day, when I go to a facility or whilst you are sitting, you get all of these correspondence from different disciplines. The psychiatrists actually are waiting for a big thing where the people who are pro or who are the voices of the mental health will come back to us. Like whilst we are trying, for example, to reduce the service pressures on the mental patients that end up sleeping on the floor at the EC because they are part of the 72-hour, but now are saying that they shouldn't, I mean, the specialized psychiatry needs to reduce the burden. There will be people who will be saying that, oh, you want to institutionalize people now? But we're trying to solve something. So what I'm trying to highlight, I do understand from the child aspect that how do we prioritize children, but noting the social determinants of health that contributes to some of what, not only the illnesses, but the whole thing about the childhood stuff, is most of them, they are not necessarily need all of them to the interventions will be coming from health. Making an example, the first 1,000 days, the most important thing that you are focusing on before that child is born. You want to be that child to be born from a mother, specifically the mother, and I was the one who carries the baby, but generally it's about the family who is healthy, who is, not to say healthy, is also well, and the environment is conducive. The person is not using alcohol. If he's that immediately you get pregnant, stop, and so forth and so on. Because it's not only about a brighter future for that child who's not even born yet, but also it's about the prevention of some of these, like the violence and so forth. So when we say, when you decide that you're going to be pregnant, if in your reproductive age, which is very unlikely in our kind of situations in impoverished communities where some of them actually they get raped. So it's not about that you would have decided. But if indeed that you have got that privilege of probably knowing, get your folic acid, get your iron supplements and everything, eat healthy if you've got a choice and all of those. And then by the time the child is born, like when we're asking, where's the budget in regard to the child health? For us, we start from before that child is born. So there is a budget there where you might not see it reflects child health, but in preparation for that reproductive age period, for example, of those mothers. And then the antenatal care part of it is part of the child health because we are going towards the first 2 years of a child's life. And then also the issue of making sure we leave no one behind in terms of the children on the immunization. I think they did speak about the measles. I think it was a member from Fafal or member Bounce was talking about the measles and everything about it. So the whole package of the expanded program of the on immunizations to make sure at least the first 5 years, now I'm adding the other years, where the EPI's expanded program of immunization, the child focuses on, it's part of the child health. And also that we go out of our way because you know that from 2 years and above, they're normally in the ECD. At what extent that we could even do the visits in regard to that those children get immunizations, the growth monitoring, that is also part of it in the first 2 years of life. Generally, we do know that in the first year, 1 year of the child's life, it's mostly those illnesses, the pneumonia and whatever, all of those are mostly, and HIV, those illnesses that could have also related to what causes the mothers to die or to be ill during pregnancy, impact on the children of those mothers. So it's a whole package around that part of it. So when you ask in terms of the child, responsive child health kind of the budgeting, you need to consider that it doesn't start at that level, but in most of those challenges that we see are the things that are related to social determinants of health. When the children are exposed to the violence, the mental issues of the children, that's why I did mention that the 30 million rand that I committed to as an additional for mental health last year, it was focusing more on the child, adolescent mental health. We even have got a child adolescent excellence of care that was initiated together with the Grooteskill and also in the Red Cross, just to consider that in some instances you'll find that the child adolescents they are left behind when on the issues of the mental health. And one of those which the psychiatrists, they came also made us aware at the time, which is what we have done now, part of the 30 million. You get in a situation, I made an example of when they're coming for 72-hour assessment, and then you have to put them in a ward. where do you put this child adolescent? Do you put that adolescent into the adult? It's not an adult. So they will end up probably abusing him or her in that ward. Or do you put in the pediatrics? In the pediatrics, they will say she or he is too old to be staying with 7-year-olds. So that's why in that space of the mental health, we even have, I think Dr. Karim or Dr. Kluge can talk about how we ended up having even a specialized psychiatrist on the child and mental health to be able to do the outreach and creating awareness, and also to be there to support some of the local clinicians around that aspect. But it's similar vein when we talk about, because I was making an example of when each and everyone will want to wants to see where is their own specialization. I think last week I went to Alexandra Hospital, which was initially designated as a rehab, but now is mental, but focusing on the senior citizens. So it's the psychogeriatric mental health services. There are 2 of those in the whole of the province. One is there in Alexandra, the other one is Deklan. I'm talking about the hyper super specialists around that, where they were saying that, Minister, we want more for the 60-year-olds and above, because they are worried about A, B, C, D, and so forth. But I say, what must I do with a child and adolescents? So the point that I'm trying to make, we have to make sure that how do we balance, but at the same time, how do we prioritize, especially for those where we could be able to make a lot of things. I normally joke and say that for me, I would rather be focusing more on investing in the young persons than if I have to choose when we've got limited budgets under the circumstances, instead of repairing broken adults. But unfortunately, it doesn't work like that in health, because if it's that 99-year-old needs care, and the priority is that 99-year-old over a 20-year-old, in terms of the prioritization, you have to respond around that. So some of those issues, like it's true, the issue of the chronic malnutrition, it's beyond health, because by the time they come to us, when we do the assessment, that's when they will say they are malnourished. Actually, even before that, because we collect data throughout, already we pinpoint that in this area, there's a high level of the stunting and so forth. Agriculture, whatever, do something. I even normally say that it cannot be in a province where we brag about the exports, agriculture exports, agri-processing, food exports. And then you get in an area where it's 100% agriculture, and the people who are producing that agriculture, that food, the farm workers, are the ones who have got children who are malnourished. I said, no, it cannot be. So we have to balance. So if it's about you bring back, I don't want to say the DOP system, but now the food kind of where we've got I used to grow up in a mine, coal mine with my aunt. You used to every week on a Mondays, we come and collect our food supplement from the mine. So if it's about that, they have to go back to that kind of, if they used to, where at least once a week, there must be some of the productions, the products, to be provided to the farm workers, and to make sure that they're being fed before you even produce, or you have maybe a quota system around that. So the issue of the malnutrition, we as health, we will not be able to solve malnutrition, because they come to the same thing with teenage pregnancy. When people say that, why are they not fixing teenage pregnancy? I say they come to us already pregnant. They are being pregnant under the nose of their parents in the communities, but to us, they're already late. So it needs the whole of society approach in terms of the child nutrition, and also in terms of their standing and everything. We can do as much, but we need everyone else. Thank you. Over to Dr. Klute.
Thank you, Minister. Dr. Klute.
Thank you. Thank you very much, Chairperson. So thank you to Mrs. Kivitz. So I'll go very quickly. So Mrs. Kivitz, when we say poorest of the poor, we know and we have the details to suggest that people in the lowest income bracket has the highest obstacles of access to healthcare. So when we talk about the equitable resource allocation that we explained to the chairperson, that is to address that. So we took resources and we put it disproportionately into the system in relation to where the people with greatest need find themselves. So for us, the most vulnerable is the people that do not have access to healthcare. And even though there's resource constraints, we still need to overcome obstacles for people for accessing healthcare. In terms of stakeholders, the minister was very clear. For us, every stakeholder is a stakeholder. Anybody that lives in this province should be a stakeholder in terms of health and wellness. And our doors are open. We're encouraging every stakeholder to engage us, to walk a journey with us, to find a solution together. Community IMCI is a very important aspect, especially in light of the current manifestation of the impact of household food insecurity. Again, as the minister said, food insecurity is a social determinant. Because of food insecurity, we will be seeing a heightened need for community-based services, community-based services to have a focus on 0 to 5-year-old children. And it's definitely something programmatically that we will be looking at and building into our program for the coming year. In terms of the 2-month salary budget, I'm not sure I understand. We've indicated to you, and it's shown clearly in the budget, that we've allocated money for transitional care. So we've got a budget allocation for transitional care. We are recruiting and selecting people against that budget allocation. The budget that's coming to the end for people that are on contracts is what's coming to end. So if we have an extension of 2 months for staff whose contract expires, it is that we're paying them against the money that we have for recruitment selection while we're recruiting and selecting the people. So I don't understand the confusion in relation to that. And then ICAS, we have a specific contract that is currently being renewed month on month until June with Metropolitan. They've been the one that we've had on contract for the last 3 to 4 years. And that's been as a transversal contract with the whole of Western Cape government. But because of COVID and the motivation that we've made, from July onwards, we will have a special contract for employee assessment only for health. So there will be a differentiation. There will be a special contract for healthcare workers because of the context that we work in that is different from other government employees in the Western Cape government. And there will be the normal one for Western Cape government employees, and both other departments like social workers can draw from ours, and our employees can also draw from the others, but there will be a special contract. That is a tender process, and it will only be allocated to come in effect from the 1st of July. Mr. Lindos, I really want to commend you, and in your capacity specifically as the chairperson of the Community Policing Forum in Belhar, in Bishop Laver, sorry, sir. And I really want to commend you for the very progressive work that you've been doing with our team, especially with Nick Newman and the EMS team. You are correct. When we do find innovative solutions and we find community structures coming together to help protect our EMS colleagues for the safe passage into picking up patients and going out without their safety being compromised, we need to obviously find what I would call adaptive policy and really agile policy to respond to that situation. It is under consideration and serious discussion in our department, as is finding innovative ways for what we call the EFAR program, which is also training community members as first responders in terms of going to a scene, helping somebody. So we are looking at innovative ways, and you are right. Agile policy is what we require, and it will be a priority that me and Dr. Karim will take back into the system. If, Commissioner Nomdu, I really would welcome, and I really welcome the manner in which your office as the child commissioner and the child advocates that's with you have engaged with our department, as you've engaged with education and with DSD in a very progressive way. We really enjoy engaging with you, and we really enjoy working with you. So thank you for that. It would really be a pleasure for us to have a session where we can actually engage and have an understanding that the children, your child advocates, actually understand the budget process and how do we make it accessible for people. So I look forward to that. To Ms. Lake, just to indicate, as Minister Mbombo was saying, I tried to find the right words for it. But I guess my only answer would be, you cannot have child health care without a healthcare system. I guess that's the best way I can answer it. And I really, really would encourage you and your team of people that have made your concerns very clearly known to really appreciate the let's call it the vantage point we take. And that's how we view what we do. We really, really take a systems approach. And from our perspective, you need an entire functioning system to look after everyone. And obviously within that, you need to have implicitly and explicitly mechanisms to prioritize the most vulnerable and have your priorities, as the Minister explained. So how to ring fence specific budgets for child health, it's going to be, I've been in the healthcare system for more than 30 years. Telling you exactly how much we spend on HIV and TB was never going to work. Telling you how much we're spending on child health is never going to work. Telling me how much exactly we spend on mental health is never going to work. You need an entire integrated system, and especially the closer you are to where people live, you need a comprehensive, integrated healthcare system that responds to the healthcare need in that area. I'll just use an example. We visited the Breeder Valley team last week. We're so impressed by them. And they took us to 3 focal points just in Breeder Valley. The first one they took us to is Sand Hills. And Sand Hills is really, really a place. And they pointed out to us, we look after the healthcare needs of everybody in this area, but there's one area where the proportion of healthcare need from children under the age of 5 is higher than in other areas, it's Sand Hills. And they took us in to say, look, what we need here is, like the Minister said, a big social determinants and a whole of society intervention, because the children are put at risk here more than in other areas because of the social conditions in this specific area. So I really, really encourage that if you want to engage us in terms of finding systemic solutions of how to actually address child health and the social determinants, we're very, very welcome in terms of that. But to ask us for finite motivations of what exactly per line item we spend on child health, it's not going to be a productive exercise for us to do that. Having said that, in terms of mental health, it stands to reason in terms of the burden that we have to face. Child and adolescent mental health will be one of the priorities, and implicitly it is one of the priorities as we work with it. As much as nutrition, any indication of malnutrition surfacing in our healthcare services is a warning sign, not for the healthcare system, it's a warning sign for the whole of society that we should take nutrition and household food security as a very, very important societal issue. And that's why we're working with our colleagues in other departments, DSD, education, culture and sport, agriculture, economic development, all of them, to say we must make household food security, and especially for children under 5, a key priority in this province. If you want to engage us on those issues, we're very welcome to engage further. Chairperson, thank you so much. And thank you very much for all the inputs.
Thank you, Doctor. Members of the public, is there a last question or two? I just want to be clear. The lady at the back, and the 2 ladies there.
I don't know what to say, but what I do want to say is that the department actually fails the standing committee. The minister loves quoting the National Health Act. Yet, the structures in this province is not working. It was written out of the annual review report last year. So the governance that the department are talking about and the stakeholders is what the department says they have structures in place. They have the Provincial Health Council, they have the District Health Council, they have functioning health committees on the ground. It brings a grave concern if we're talking about stakeholders in the air. Stakeholders are people that has a clear interest of health in this province as well as in the city. And I think the department needs to explain to the Portfolio Health Committee about the governance structures when it comes to compiling the APP and the annual report. Thank you.
Sorry, the lady at the back.
Good afternoon. My name is Amanda Davids. I'm an activist first, and then I'm also a trauma and substance abuse counsellor within the community. I want to go back to child health. I want to know, is there oversight over medication given to children? Because as a substance abuse counsellor, 9 out of 10 of the adult substance abusers has been on Ritalin since they started school. And at the moment, I'm working with the primary schools in our area, and there is not one classroom where you won't find 5 children that is on Ritalin. Is there any oversight whatsoever? And why is it that it is being doled out at our clinics like with vitamins? Thank you.
Thank you. Doctor, do you wish to respond? I
Yes,
see the minister's, Doctor, my apologies. I see the minister's hand is up. Minister?
Yeah, okay, thanks. To Mama Ukevitz, I think it's because we have a history of this conversation. I think the other people might not know exactly what he's talking about. But generally, without even going there, but generally, Chair, the National Health Act, again, I have to go back there because I have to observe the rule of law as an executive authority, that it talks about establishing the District Health Council, which is all have been established, and we have done the whole of the roadshow with all the district health council, which are chaired by the district mayor. In the metro, the mayor gives that to the MMC for health. I think the last meeting, it was, I think, 2 weeks ago, is the one that has also confirmed what we, the department, has been committed to in regard to the Atlantic. I'll share it at my budget speech. So these are functional. We have done that part. The other part is about the other structures, as according to the Chapter 6 of the NHA. It's about the clinic committees and the hospital boards, which is we ended up having the 2016 Act so that to be able to, which is the Provincial Act, which we could be able to accommodate the primary healthcare clinics, because there are too many, especially in the rural, where it becomes difficult when there's only one professional nurse in that clinic. And also some of them, these clinics will find that they are satellites, but there's maybe 3 satellites, but 1 main clinic. So all of those are functional, but again, the issues of the distance and also the issues of the some of them where they are not available at the time of the meeting is one of those kind of things. And the others might not necessarily complete their time, which is the 3 years. So that's why, as a start to show appreciation, because you don't pay them, they are community members, they are representing the anti-servers. But because some of them, once they volunteer, they need the issue of the transport and all of those, which is part of, we do the provision. So that's why, as a start, we're just going to be giving them the appreciation to show some of the appreciation around that. These are functional. And also of course, the Provincial Consultative Council, which is also various stakeholders. I did mention that part of the stakeholders, especially during the COVID, because it's only now, this year, that things at least now are trying to breathe and trying to go back, if we ever go back, to some of the normal stuff. But the engagement with the universities throughout, where we have been actually be the ones who will be providing evidence-based in terms of now we're going to do the vaccination, whatever way, or the testing and the screening, whatever way, based on this, because we had subcommittees within those, like a subcommittee related to the protocols on how the police could be able to manage COVID and so forth. We have been engaging instead of having that one big meeting of everyone and then become a talk shop. It's about you consult with the academics, you consult with the private health, you consult with the various structure of the communities, whether it's a correctional service and so forth. So it has been functioning throughout. So what member, what Mama Kivitz is actually saying is about her Metro Health Forum is the one that has been championing that it needs recognition. And again, I keep on saying that a forum is a forum. We recognize the forum. But work is happening at the local level. It's up to the clinic committees or hospital boards that they can join the forum, but their responsibility and accountability rests within them. So that's just the clarity that I just want to highlight. And then lastly, the response, on the substance abuse. I think Dr. Kruti can add the note and BNB. It is South African national policy, as is according to the Substance Abuse Act, that substance abuse is a custodian of social development, as according to the Act. And it's supposed to have a multi-sectoral approach, which is we are part of that. I think Dr. Kruti did mention in regard to the opiates, like it's a heroin, I think so, of this that kind of a substance, like in Stetland, we do have a unit there for the detox. But generally, all of us participate. And for example, in that act, I think it's section 44, I cannot remember, that talks about what is our role, especially after the 72-hour, or for those people who probably would have been identified to be using substance. So, and also they are addicts, how we can be able to use that loophole to prevent them ended up having a substance abuse disorder, which becomes now a psychiatric condition in terms of what could be able to do. But generally in South Africa, that's why some of other people say, why don't we give medicines or something for people to stop using alcohol or whatever? Say, unfortunately, it's a national policy that who's the custodian. Because if you read that act, it talks about the Minister, Social Development and so forth, and the multi-sectoral approach. We are part of that. And like I was asking a question now about the municipality's role in terms of the local communities, in terms of the substance abuse, in regard to some of those aspects. Because even if things, and we are not a custodian of some of those things, but because we absorb everything, we don't fold our arms and say that, that's social, that's whatever. We make sure we participate because we are trying to make sure that we don't keep on mopping the floor. Preventive, promotive is part of the types of care services that we render, but you have to reach out to the others. I think in terms of the specifics, that why can't you give what's medication and so forth, I think it's clinical. Dr. Kruti, over to you. Thank you.
Thank you, Minister. Dr. Klute.
Yeah, no, thank you. So I was just going to thank you to the two additional comments. I think the Minister has responded to Ms. Kivitz. There is a history, Chairperson, with the Cape Metro Health Forum and its relationship with the department. I do invite Ms. Kivitz and members of the Cape Metro Health Forum, if they so want and so wish, that we have a sit down and just have a conversation about the history and what the current context means for stakeholder engagement. In terms of the specific comment that the additional member from the public made, sorry, I didn't get a surname, but it's a really a keen observation. And I just want to make a comment. In a previous life, before I became a manager, I was a school medical officer. And one of the key things that I was tasked with is what is the oversight and what is the controls in place so that Ritalin use is effectively managed and there's effective oversight. So I do believe, and there is undertaking between ourselves, especially in the metro. I know it's also with the regional, with our regional hospitals as well, that there are oversight in terms of effective, let's call it therapeutic interventions in childhood for the right things, that could put them at the risk for future substance abuse. And I do believe it's an important issue to be looked after. It will sit under the clinical governance where pediatrics and psychiatry meet. And I do think it's something that we will take up as part of our clinical oversight responsibility. Thank you, Chairperson.
Thank you, Dr. Kluter. Members and members of the public, we've come to the stage where, if they want to, I'm going to ask the Minister and Dr. Kluter to make some concluding remarks, if they have anything to add. And we will go to that at the moment then. If the Minister is available and do wish to make some concluding remarks, Minister, you're welcome.
Yes, thank you very much. Again, as Dr. Kluti keeps on saying, and it's what's the theme that has been throughout in the department, health is everybody's business. We appreciate the role that is being played by Parliament as another arm of the state in not only making us account, but even the ideas, because you mustn't think that we are here just only to waiting to what will be the response. We do absorb some of the inputs, and then we go back and regroup and see what is it that probably we are not probably communicating properly. That member XYZ could be keep on asking these questions. So we take your inputs from the standing committee very seriously. For the community, again, they will come here taking the whole of their time. It's not that the members are the ones who are really sick, but they are representing the anti-SARAs who are there, which is they have to go and feedback. And the amount of time, because you hear members of the community saying, according to page 240, whatever, something like that they even have to go to that of reading all of those things. Yet it's not even part of their main jobs. At least with a committee, portfolio committee, standing committees, about it's part of their responsibility. But for the members of the community to take time, not only to read, but also to bring it here. So that's why if it's so, because it's a short time, if it's so happen that there are other issues that they will also want probably to engage us with, we are always available for us to continue, because we do know that they are not doing it for themselves, they are doing for the communities where they are coming from. And then with the staff, with the government department, for DALA, whatever you must, not only in compiling the budget, but also to make sure to provide answers. Because people think that probably I'm clever, that no, they don't understand that I go to a classroom from the department, whether I'm meeting with the corporate service manager or with the HR manager, with the strategic manager, or with the IT manager. I get taught because I ask questions, and then they say this is, and then I'll be able to say no, or they'll be able to say so. Thank you for the department for doing that, because you are not only sitting there to represent yourselves in your positions, but you are carrying the mandate and also the voice that comes all the way from the Maritzburg, from the cracks, from the clap run. I'm just mentioning the outlayers there. For that. And then lastly, Chair, again, remember, health's everybody's business. It doesn't stop the committee to ask to invite the National Health, to invite the National Treasury, to do the explanation in terms of that. What are the indicators? What is it that you allocate budget as such? Because I didn't want to talk about it now, but the issue, for example, when we say we want to decongregate or to be able to continue where we give services outside, primary health care services, we drop the medicines, we do the hubs, wellness hubs outside. And then the national, they'll say, we are penalizing you because your head count at the clinics has dropped, but not recognizing the head count that is happening outside, because we are Department of Health and Wellness. Some parts of these components, they don't have to happen under the roof, because we don't want to have a situation, what if there will be another pandemic? We don't want a situation where we stop or pause other services and they say, go home. We want only 2 or 3 people. We still want to continue irrespective. So going forward, Chair, we are building a system that not only will be resilient for the Western Cape, not only will be equitable and affordable only for the Western Cape, but we want to do it for South Africa, because at the end, we are all South Africans. Whatever affects Limpopo, it will also affect us. And for some of us as health professionals who came into this profession because we wanted to contribute, there's no way that you can leave it like that. So thank you very much for all what you do. Please keep on helping us. And noting that we don't want to create binaries, that it is a community, it's a standing committee, it's whatever. We are all together, especially like now, the last one, Chair, now. Now we've got a few months before it's the elections in 2024. So there's no guarantee what is going to happen then. So some of us, myself specifically, which is guaranteed that I'm not talking about the government, the cyber can continue, make use of this opportunity to see what recipe that you can be able to build up, not only for the Western Cape, but using the Western Cape to pilot some of those kind of the brilliant ideas. But we take it, help us when we want to sell some of these ideas to the national, which is they're normally actually very, very much welcoming about it. Because at the end, health system in South Africa has got cracks and the COVID has exposed it. Western Cape is not actually immune. We might be doing far much better than the other provinces, but there's still a lot to be done. Thank you, Chair.
Thank you. Excuse me. Thank you, Minister. Dr. Klute.
Yeah, Chairperson, thank you so much. And just to say thank you to the committee and the members, and really for the manner in which you always engage us, held us to account. We take this very seriously, and we really come and do what we need to do in the best interest of the people of the Western Cape. So thank you for that. For the members of the community that made the effort to come today, and has made the effort to really engage on really key issues, I really also commend them and thank them for walking that journey and taking the effort to do this on behalf of the people in this province. For my own colleagues in the room and for the colleagues that works very hard at this, as the Minister said, we are extremely proud. I'm extremely proud to be the accounting officer of such an exemplary team of people that are 100% committed to serving the people of the Western Cape and of the country. I would be hard-pressed, I think. You would be hard-pressed anywhere in South Africa to find a more competent and a more dedicated team than the one in the Western Cape. So I'm extremely privileged to be part of this team, and I'm very privileged to call them my colleagues. Having said that, as the Minister has indicated, we are going into a 3-year period, potentially a 5-year period, which is quite defining, and it will be defining for the healthcare system in this country. We believe that this is a time to call everybody to come together in action. I think opposition and adversarial relationships has got a role, but working collaboratively together towards one common solution is probably what is called for. And it can be a defining moment of finding the right balance of working together and finding solutions and shifting what potentially could be a benefit for generations to come. So I really call on everyone to really take hands, come together in the spirit of collaboration and really for the future generations. One thing I would like to say, and I know there's child advocates sitting in the room, but if we really can put ourselves in saying, can we do it for the 0 to 5-year-olds that are currently under the age of 5? And really imagine what the healthcare system would look like when they become 25, 30 years old. So really having that kind of commitment and give them the kind of healthcare system we want to leave the legacy for the people of the Western Cape. Thank you, Chairperson.
Thank you, Doctor. It's now my turn to do some non-healthy speak. And firstly, I need to thank, this was scheduled for a different date. And if I've convenienced anybody, it's not me. I'm not going to point fingers. If I have to point fingers, it's probably to the IEC who decided to have by-election yesterday, and it happens to be the by-election where I'm allocated to, not the by-election, the town that I'm allocated to. So my apologies for that, but it was just not practical having an election yesterday with a holiday in between the special votes which took place on Monday. So my apologies for that. Thanks for your understanding, and I want to thank the Minister. Minister, thank you for the manner in which you are leading your department. I always say I admire your commitment, as I admire the commitment and the passion of the department and all the officials, Dr. Kluter, who are present here, Dr. Karim, Dr. Carrick, Ms. Nkosi, Mr. Kay, and all the members of the department online. I really salute you and I really look up to you. Thank you for your absolute dedication. And then I need to turn to our members of the public, our guests today. Thank you for coming out, as Dr. Kluter has also said or referred to. It's heartening to see people still interested, and I hope that in future there will be many, many more who can come to this occasion, which is the budget for the Department of Health, and that we will make progress, as Dr. Kluter said, in a meeting of minds on how this department is interacting with those who need their services. So on that note, and this is quite unpleasant, and I've never actually, this is my third health committee meeting, and I haven't found a way of asking you to leave actually. Because we have to proceed with our business, but obviously not in your presence. So I don't have any other place to go, so you will have to leave here. So thank you for coming, and it's much, much appreciated, and we hope we see you on many, many more occasions when this committee is sitting. Thank you. Keep well.
You can report about eating health and wellness. Oh, look. Yo, tipo amigos and printando. You need to report of performing committee on health and votes in the check into the system
Good morning. Good morning.
Wellness system. Votes itself and wellness. And wellness, no? And the shaking. Then in committee and social.
It's probably on. It's not on my screen. Righto. Councillor Barnes is, sorry, my apologies. I always say Councillor, I'm still in speaker mode. Member Barnes is, oh, there's Member Windvogel now. I somehow.
Yeah, I'm still here, Chair. We are not in council.
Good. Thank you very much.
I miss you guys.
Yeah. Members, are there any resolutions or requests for informations or recommendations from this budget that was presented by the department? If there are, these will be included in the minutes and not in the report. Can I get an indication whether there are any resolutions or requests for information?
None from my side.
Member Barnes? Member Barnes, your hand is up.
Yes, Chair. Yes, Chair. I think I have two resolutions that I would want to raise that came from the meeting. The one was on the question that I asked with regards to transportation when the MEC started giving her input, saying that transport has been a challenge within the department. But on her response, they've said that they are having plans that they are putting in place. I would love them to furnish us with a report of what the plans are, or maybe a briefing, just something for us to see where they are. My apologies for my baby that is making a noise here, Chair. It's already late. And then my second one, Chair, will be on, where is that? I just made notes here. Okay, Chair. A list of all specialization services rendered at Khayelitsha District Hospital and the Mitchells Plain Provincial Hospital, as well as the other regional hospital, Chair. I think when they were speaking of the differences between the hospitals, that was one point that I really needed clarity of that. Also, the number of beds at ICU and ICU at KDH, and at Mitchells Plain, as well as other regional hospitals, Chair. I think that is what I wanted to and what is the need for high care beds at the KDH and at Mitchells Plain Hospital. I hope I was a bit clear on that one, because my notes are a bit confusing.
So recorded. Thank you, Member.
Thank you, Chair.
Are there any other resolutions?
Chairperson, from my side, no other resolutions or recommendations. I think some days ago, out of the same big document, budget document, I made a number of recommendations, so I leave it at that. Thank you, Chair.
Thank you, Member Plato. Well, then we moved on to the consideration and adoption of the committee report on this vote. And therefore, the committee report is tabled, and it reads as follows. The report of the Standing Committee on Health on Vote 6 Health in the schedule of the Western Cape Appropriation Bill, that is in brackets B2/2023 or 2023, dated 23rd of March 2023, is as follows. The Standing Committee on Health, having delivered on the subject of Vote 6 Health in the schedule of the Western Cape Appropriation Bill, B2/2023, referred to in accordance with the Standing Rule 188, reports that the committee supports or does not support the vote. And here I have to ask the committee whether the vote is supported or not. Member Fry? Member Barnes?
Apologies for interjecting, Chair. I would like to raise the Rule 90 or from the minority view. According to the ANC is not supporting this budget, Chair. Thank you.
So noted. Member Windvogel?
Huh?
No, Chair, Member Barnes covered me. We are not supporting the vote.
My apologies. I thought it was the other way around.
Chair, I move that we support the vote.
Thank you, Member Fry. Seconded by Member Plato. In that case, the following is held up to you or presented to you. Report of the Standing Committee on the Health Vote 6 in the schedule of the Western Cape Appropriation Bill, that is B2/2023, dated 23rd of March 23, as follows. The Standing Committee on Health, having deliberated on the subject of Vote 6, Health, in the schedule of the Western Cape Appropriation Bill, in brackets B2/2023, referred to in accordance with Standing Rule 188, reports that the committee supports the vote. And then there's a minority view. In terms of Standing Rule 90, the African National Congress expressed a minority view not to support the vote. The committee report supports the vote with the minority view of the African National Congress. Member Fry?
Chair, I move that we adopt that report.
Thank you so much for that, Member Fry, and seconded by Member Plato. With that, members, thank you very much for your patience and your participation and your presence. This meeting is adjourned. Thank you very much.
Thank you, Chair.
May I ask, so tomorrow morning's meeting will not...
Chairperson, Chairperson, you are not congratulating us. You are not congratulating us.
It was a fluke. It was a fluke.
I'm doing it. I hope I'm not being recorded. I'm doing it off the record, clearly off the record, but congratulations, Member Van Vogel.
Thank you so much.
He's still Babalas. Don't record that. He's still Babalas.
Bye-bye.
Bye, Rich.